So good morning, everyone. Welcome to the second day of the Giant Health Show. It's great to have you all here in the stage two of the show. We had a really great day yesterday. It's really awesome to have everyone back in a venue and connecting and meeting and seeing what progress has been made whilst we've been away, as it were. So a couple of years since we were at Stamford Bridge running Giant in person last time, which was a different sort of venue. So today I'm going to be your MC and looking after this stage. So it's a great privilege to be here doing that. We have quite a range of different topics and people here talking about all sorts of things. So we're starting off in a moment talking about female-centered technologies and female founding and all the challenges and issues around systemic bias in that space. And that's one of the tracks that Thrive are putting on. And we also have something at the end of the day that we're doing as well around age-related and healthy aging. So please do come to those two. But in between that, we have a load of exciting things as well. Firstly, from the AHSN, so a fantastic network of people working in and around the health service and offering, I guess, connection with innovation and connection between people who are looking to get technologies out there. So that should be a really great show at 11:30. We're looking at IP and specifically some discussions from the Wither and Rogers team at 12:30, and after lunch 2:30 we are going to be looking at real world evidence at scale using advanced analytics, and that should be very interesting. That's one of the McKinsey sessions. After that, a fireside chat with another team from McKinsey looking at operationalizing advanced analytics in real-world evidence. Bit of a mouthful, but sounds interesting. And then we'll, as I say, finish off the day with the second of the Thrive sessions. So that's the running order. We have a reasonably long session for coffee break and networking at 10:30. So if we drift into that a little bit with this session, being as we started a little bit later than planned, there's been a little bit of confusion about getting people in and what the start time was. So we'll be potentially drifting to that if we need to. Depends what happens, through the discussion and what questions come up. I am going to really be asking in this first session for input from the audience. I'd love to sort of hear what people are up to, what your take on the topic is. And I'll ask you in a moment to kind of give me a bit of an indication of what sort of category you fall into in terms of academic or health person or so the first of today's sessions is looking at serving women better through technology. And it's a really important area, both because from an equality and diversity point of view, it's massively underrepresented, as we all recognize, I hope. And from a business point of view, it's a fantastic opportunity as well to bring new products to market and to create innovations in that area. And that is really ripe for disruption, as they say. So without further ado, I'll just do a bit of an intro into Thrive and the session. And we'll start by, we've seen our panel, we'll come back to them in a minute. So Thrive are a team who work on creating technologies in the wearable space, and we look to create things that have really significant impact in terms of health outcomes. The opportunity more broadly is that health systems are in a bit of a shambles. There are many opportunities to do healthcare better. As we all know, probably from interacting with the NHS, it's a very reactive organization, and we want to try to create technologies that we can introduce into the NHS and to other private settings that have that disruptive and kind of high impact effect, mainly based on data, on real-time measuring, and bringing those things together to create different health pathways. So that's what we focus on. We have some different ways of operating in terms of our business, and we can talk about that a bit more later. But our team comprise basically physical device development people, digital services, so we do apps and web interfaces and those kind of things. We also work extensively with data from the point of view of kind of physiology measurements, normally looking at body signals and interpreting those, so real-time data, and then trying to run algorithms on wearables that have the effect of making those wearables more user-friendly in terms of how they connect with the rest of the world and those kind of things. So we're focused on those areas and developing into the health and wellness space, as I said, predominantly fitness, those kind of areas as well. A couple of just case studies for the things that we've been working on that are relevant to this session that we're going to do today. So this is a belt that we've created for a team over in France who wanted to look at pain management non-invasively for specifically period pain and endometriosis, which are huge unmet needs. So just sort of relating back to this topic today, there are these markets that are emerging that have real fantastic potential from a commercial point of view. And this is probably a good example of that. So we've worked on this for quite a while, through lots of stages of prototyping, and it involves quite a few traditionally disconnected industries. So fabric technologies and electronics are sort of coming together slowly, but it's quite a difficult thing to bridge those two. And we're really excited by some of the opportunities that are emerging there. This is non-invasive pain management using vibration and heat therapy, essentially. And a really exciting project that we've worked on for quite a few years in relation to breast cancer. And again, this is a sort of fabric meets hard technology situation where you're trying to measure something with electronics, but you need to pay attention to ergonomics and to human factors. And again, it's a really fantastic example of an unmet need. This is a continuous monitoring system, or a spot monitoring system that is much more continuous than the standard mammogram that you would have in a clinical environment. So this is something you maybe could use once a month, once a week to keep track of potential issues, especially if you have genetic issues in relation to breast cancer, for example. So another good example of both what we do and also the sort of fabric electronics bit. We're quite development, and it's relevant to many markets. So we work globally, and we've got lots of projects all over the place. And here are a few of the people that we've worked with. So what I'm going to do now is just go around the room and just kind of try and put people in these boxes a little bit. So bear with me. I want an answer from everyone, just so I can get a sense of who we've got in the room. Hopefully these categories cover everyone. You can be in the other one if you want, but don't all go there, please. Or otherwise I'll have made a complete mess of understanding the room. Are there any investors in the room, first of all? Anyone investing into technology? Okay, fantastic. So we've got one investor, people who consider themselves predominantly as entrepreneurs at this stage. 1, 2, 3, 4, 5 entrepreneurs. Academics, anyone in the academic space? One academic. And people in a corporate or SME environment coming to the show. You're both in. Okay, corporate, cool. So three, was that 3? Hands up again, yeah? 3 there. So who didn't put their hand up? Everyone else put your hand up. 2 at the back. I know you 2. I know you 3. So we've got 5 people there. Anyone else not in one of these categories? Okay, so at the back, where are you from? A law firm. Okay, awesome. So patents and that sort of thing, or general law? Okay, awesome. Fantastic. So we've got a bit of a mix, as you'd expect. So that's good. I did kind of just about get the categories right. That's cool. Let's see if we've got the others on the line. Have we got the rest of the panel? Right, so we're going to jump into the panel discussion. Serving women better through technology is the broad theme. And hopefully we will bring in, yay, hello everyone. Looks like they can hear us. How do you want to do this, Anna? Should we, yeah, if you grab a mic, maybe I'll grab one as well. Yeah, should we sit inside? Fantastic. You all well this morning? You can hear us all fine? Yep. Fantastic. This is my first time doing any kind of virtual curation, so you'll have to bear with me if it goes wrong, but I'm sure we'll get it sorted. Anna will look after me, so we're all good here. Great. I think we'll start with the obvious, which is some introductions. Anna, as you're here, let's jump in with Anna Goodmanson, please.
Sure, thank you. So my name is Anna Gudmundsson. I'm co-founder and CEO of BioSelf Technology. And together with Thrive, we've developed the Sensate, which uses infrasonic vibration to tone the vagus nerve, very effective for stress and anxiety and a lot of other things. So it's my excellent co-founder, Stefan, who's the innovator and the sort of, from the medical perspective, clinician behind. I've actually programmed over 15 years ago. I've been in senior management roles for the last 15, 20 years. I've been in large, small companies, raised money, scaled, sold, etc. And I also have a huge passion for human evolution and how technology can be changed for good and have a really positive global impact.
Fantastic. Thank you, Anna. Let's start from the top left. Annika, would you like to introduce yourself?
My name is Anneke van Ome, and I run a wearables and soft goods design agency in Rotterdam, Netherlands. Therefore, also joining remote. I've been working in the field of wearables, especially medical wearables, for over 10 years. And Jacob just explained the project with Zetsen, the breast project. And I've been working on that one as well. So I have some experience with femtech projects. But especially with product development for niche target groups like children with Duchenne muscular dystrophy. There's a bit of an echo from the venue, I guess, in my mic, so it might be a bit weird to explain. And I can see the venue, so it's a really odd experience, but I hope I can contribute something nice to the panel discussion as well.
Okay, thank you, Annika. Yeah, we can hear you fine here, so apologies for echoes at your end. Hannah, would you like to introduce yourself, please?
Of course, yeah. So hi, and I hope you can hear me clearly. I'm Hannah, and I'm the co-founder and CEO of Juno Bio. So I have a background in biology and biochemical engineering, and I worked as a microbiome scientist. And microbiomes, for those of you that might not be familiar, are all the microbes that live in and on us and have a huge impact on our health and wellness. Working in this space, I was just extremely shocked by the lack of work, research, products for women when it came to the microbiome, and specifically the vaginal microbiome, because it's implicated in over 30 conditions that affect billions of women worldwide. So I formed Juno in 2018, and at Juno we decode the vaginal microbiome to close the gender health gap. We ran one of the world's largest studies in 2019, and last year we launched a vaginal microbiome test that gives women unprecedented insight into their microbes and what it means for them, and also powers up research on the back end as well.
Fantastic, thanks. Great intro. Sophie.
Hi, my name is Sophie Smith. I'm the founder and CEO of NAVTA Health. Just as a heads up, I think we virtual participants can't hear each other speaking at the moment. So I'm not sure what Hannah and Annika said in their intros. NAVTA Health is a hybrid healthcare company for women. We are headquartered in the UAE. We enable women to detect, diagnose, and treat chronic diseases, focused on, I would say, underrepresented populations in clinical research and trials in the Middle East, Africa, and South Asia. We had a slightly dubious privilege of conceptualizing this hybrid healthcare model back in 2018, actually long before the pandemic hit, combining digital and traditional healthcare along clinical pathways to enable patient-centric, decentralized care with a kind of augmented intelligence overlaid. It's hybrid. Everything is now becoming a lot more mainstream, which is good to see. In terms of my background, I worked as a technology consultant with Accenture for 4 years. I actually have a degree in history. I then went through the process of setting up a number of different enterprises focused on emerging markets, a doctor finding appointment booking platform in Pakistan, a plastic recycling company in Sierra Leone, before landing on NAVTA, which I hope will be the company that I run for the next 30 years.
Sophie, have we got the technical issues sorted? Can the rest of them hear each other now? Yeah, that's all good. Fantastic. I also want to say a warm welcome to our audience online, because I believe we're live streaming as well. So the sorts of people out there hopefully tuning in to this session. I'm not sure if there's a conduit for questions to come from out there, but if there is, please get those coming in as we go through the session. And likewise in the audience, get your questions ready as we start to go through this session, because it's going to be a bit participative if you're willing to work with me on it. Okay, so I'm going to start by diving right in. And I'll put this one out to the floor really and see who wants to pick it up. There's a bit of a conflation between the terminology femtech and sex tech. I'm not sure if I like either of those terms or understand that conflation. Can anyone sort of target that and tell me more about what they reckon?
So I think this is something that has been covered by Dr. Brittany Barreto of Femtech Focus actually on a number of occasions. Femtech Focus, now an official partner of Crunchbase, has recognized, I would say, or started to recognize the potential of the women's health technology industry, broadly speaking, valuing it at $1.186 trillion by 2027. And this is split across a number of different segments, of which reproductive or sex tech is one. Chronic diseases is actually the largest segment at $218 billion. But I think, yeah, it's important to recognize that when we talk about women's health technologies, we're talking about things that are able to materially improve women's health in general. Again, acknowledging that women were mostly excluded from clinical trials until 1994, which means a whole load of different things. But for example, women are still 50 to 75% more likely than men to suffer adverse reactions to drugs, because a lot of drugs, a lot of medical devices, a lot of procedures haven't actually been designed to cater for women. So when we're talking about technology that can improve health outcomes in women, we're really speaking across the board. And it's very common to have women's health referred to as a niche. But again, when we're talking about women's health, we're talking about something that can improve health outcomes in over half of the global population. So it's a lot broader with then many different verticals underneath it.
Yeah, I guess just to the point that Sophie said, it's incredible to consider that women were largely excluded from clinical tests until 1994. So that is just so recent. And just the fact that, I was on a panel recently with Helen from, forgot her company. I think you know her as well. And she pointed out that pretty much when we talk about health tech, there's actually man tech, and that is only representative of half the population. So, and then I was also going to make the point that hopefully both men and women have sex. So sex tech clearly shouldn't be something for only women.
Yeah, I completely agree. Really, just crazy that we've got that data gap. Is there anything else that people have experienced, or that kind of relates to their work in relation to that data gap issue? Because it's so broad. I mean, we could have an entire session just on that, I suspect.
I think there are a lot of really nice examples. One, for example, is that there isn't currently a single wearable device on the market that is capable of accurately tracking steps if you're pushing a buggy, which for women who are trying to recover postpartum is obviously something that's pretty critical, especially if you've been very active prior to conceiving your baby. And the reason for that is because most wearable devices are designed by people who are not primary caregivers and don't push buggies, be they male or female. And so that's one example, but there are dozens.
Hannah, do you have any challenges in your work in terms of, firstly, the microbiome, which is quite a new thing in terms of being, I guess, productized and being turned into something of relevance, and then the data gap on top of that? Tell me about how you kind of validate what you do.
Yeah, it's really interesting because when it comes to the microbiome, yeah, it's a completely newish space of medicine. And so there's obviously a gap in terms of research and data just broadly because it is an innovative space. But the funny thing is that all the challenges that people might normally associate with the microbiome aren't always at play when it comes to the vaginal microbiome. The vaginal microbiome is sort of ripe to be taken to the clinic and to be taken to the patient and used in a meaningful way. And I guess it's a shame that wasn't one of the first microbiomes that people focused on. even though, you know, a lot of the challenges that stop, you know, gut microbiome research, etc., being translated don't apply to it. And obviously the gap then specifically in women's health in the microbiome world is huge. There just hasn't been enough funding, enough work, enough research into it. So, I mean, that challenge is the challenge that Juno Bio is trying to solve.
So quite a big challenge, and lots of blockers, which I guess is a theme across many of the areas we should probably talk about. You know, blockers and things that have been put in the way historically and that remain in the way in terms of being able to get traction in this space, both from a research and data point of view, a systemic point of view, etc., etc. What I did miss at the beginning of this was to set the scene a little bit. I dived straight into these really relevant questions because I was a bit excited, but we agreed to have a kind of a sort of goal, I suppose, for this session, which was to explore the state of play, opportunities and blockers in the development of products and services for biologically female users and for female identifying founders facing systemic bias. And I think all of the kind of discussions so far, you know, really do link into that systemic part of the problem. You know, when you look at the media and you see changes both from a diversity in terms of race point of view and from a women point of view, do you feel that we're getting there, or are we just really not getting there and it's all just sort of spin? How far along that path are we to some kind of transformation in that space?
There was a really interesting report. Oh, go on.
Yeah, I was saying, if I may, from our experience at Juno Bio, having, you know, started in 2018 and now it's 2021, we've seen that while there's a lot of work still left to do, there is a lot more attention being paid to femtech and just the women's health and space in general. So we've seen a massive increase in the amount of investment that goes into companies like ours, and also we've seen policy and policymakers start to pay attention to this area. And so I think this year, some of you might be familiar with the announcement from the government that they are working on a women's health policy. And a lot of the companies that we know in Juno Bio as well are contributing to changing not just, you know, the startup landscape or that in that sense, or the academic landscape, but policy as well. So I think there's a real shift to meaningfully changing and closing the gaps that we see.
That's reassuring. Sophie, do you want to jump in?
Yeah, I was just going to echo what Hannah said. Actually, I think this year we've seen a shift in frustration levels more than anything else. The statistics were there before, but there seems to be now a real collective frustration with the fact that in terms of capital that is really available for female founders, and female-oriented companies, there's not only is there not been a change since the pandemic, but we've actually gone backwards. For example, and again, it depends on which part of the world you're in, but in the Middle East, we have had a record year for funding this year. I mean, Femina closed a large amount, almost $2 billion. 0.9% of that has gone to female-founded companies, which is about the same materially, so it's about $18 million that was invested last year, but proportionately it's fallen by 50%. And there are a couple of things that have contributed to that. Fewer deals, larger deal sizes. And one of the issues that we see, and it's something again that's been reported on a number of different times, is that at pre-seed and seed stages, where you are judged based on your potential to scale, your potential to innovate, your potential to generate revenue, women are judged much more harshly than men. Women tend to be judged in general based on what they've achieved, and men tend to be judged a lot more based on their potential. And so once you reach Series A, where it's all about unit economics and about traction and about revenue generation, the playing field actually levels off. Still, there's quite a disparity in terms of ticket sizes, but in terms of your likelihood of securing funding, that levels out a bit. The problem is that a lot of female-founded companies don't get there, and either they don't raise funding or they go down a completely different route. One of the things that was quite shocking to me last year, and we did the F-Lane Accelerator for Female Empowerment, which was a Vodafone Institute, Mohammed Social, Yunus social business initiative, picked 10 of the top companies around the world that were working to empower women in emerging markets, was that when we had people come in, and very, very high profile people come to talk to us about investment, the universal piece of advice we received was, don't even bother going down the angel investment venture capital route because you're women. Look for grant funding, look at crowdfunding. And when that's coming from top professionals in the field who are supposed to be supporting you and opening doors for you, and they're saying, I'm sorry, but these channels that apply to male founders don't apply to you, you know there's something wrong. I think, again, trying to hammer home actually what these statistics means is really important. If you, Jacob, was sat in a room with any one of the women on this panel with a startup, and there were 100 investors in the room in the Middle East today, 99 of those investors would give their money to you, and just one of those investors would give their money to one of us. That's the difference that we're talking about. We go through schools and universities being taught that we are equal. We have the same amount of time in exams. We have the same number of hours to study. When we picked for teams, the teams are the same sizes. Everything is fair. And then you step out into the world of work and you set up companies and you start trying to pitch for funding. And suddenly the odds are 99 to 1. And something has got to be done about it.
Wow, that's a compelling situation and one we should definitely look at. I'm going to sort of take that less positive note after Hannah's started for 10, and ask Anna what your experience is in Silicon Valley. I know you're over there a lot, raising money all the time, as many founders are. Tell me about what it's like going into a room in LA.
So I think we're at a really interesting place where there's a lot of conversation about the topic, but it's not showing in the statistic, like Sophie just said. So also when we look at the percentage of funding going to female funders, we talk about something like 18%. Actually, 80% go to male only. And then we got 2% that go to female only. And then the others there is one female founder. So it's also just looking at what those statistics actually mean. So having been in the industry and also raised money for some time, and I'm going to be very brutally honest here, we sort of passed this stage of inappropriate comments and like this kind of very obvious sexism, which indeed, I mean, having been for 20 years in the technology industry, there was a whole bunch of that as well. So no one is now going to talk about what you're wearing or necessarily chat you inappropriately and all that. So we kind of passed that. So now we're at a challenging stage where it's all unconscious. And so what I'm experiencing right now is quite interesting, is the amount of compliments we get as women for our achievements. So our startup, for example, we have, I'm going to be very honest here, so sharing, we've only raised 2.5 million to date. We've developed stable hardware, stable firmware, stable software, and we've had revenues of over 3.4 million. As an early stage company, this is really good. And I get people are telling me, Anna, it's fantastic what you've done. And, also some investors ask me to give advice to other portfolio companies, how they've done it, etc. And then I'm going, why aren't people throwing money at me? And I'm just sharing as an example. But then I look back at my career, and actually it's quite typical that you sort of expect it to be a superwoman. So we give compliments to women and we invest in men. And this clearly is the case if we look at the numbers, right? And so now this is very subtle, difficult, unconscious bias we get to, because not a single man or woman would know that they're making these decisions. They say, oh, a lot of people, so it's going to be so easy for Anna to raise the money, the product. Oh, I should mention as well that the user statistics are like 10x competition. So, and I think that's the challenge now. And what do we do? Because similarly, obviously, in many other areas, I'm in dominant group in terms of being white, in terms of not being of certain religions, not disabled, etc., etc. So we have to educate ourselves. And now moving to the United States, there is a very different sort of landscape in the racial area. I grew up in Sweden, so I had to read books. We have to understand, and I think that's as well what we need to do. If we're not actively trying to change the situation, we are part of the problem. And I think that's now where it's harder to point at what people are doing, and it is up to us to educate ourselves and be the change. I see a lot of shift in terms of conversation, but it's not yet turned into any change in the numbers.
For sharing this, sort of again quite shocking. I'm assuming that the rooms you go into are still predominantly white male, so that's a sort of finance and money problem even further up the chain. Hannah.
Yeah, sorry to have interrupted there. I'm conscious that there are two sort of things at play here. One is investments into companies that are maybe focused on women in terms of their products, and then investments into companies that have female founders. And I wanted to throw it to the panel whether they've experienced a difference in those two aspects of it.
Yeah, I have just a very little anecdote here, actually, which was a male-funded company that made a like sex toy vibrator as a piece of jewelry. And they raised loads of money, and it never got anywhere because there was actually no women that wanted this particular product, but they got lots of funding that didn't go anywhere. So I'm sure people have better
another great example. Another great example of that was Pinkygate. Did you read about Pinkygate last year? So Pinkygate, I saw a hand up in the audience. Yeah, that's how I feel. So Pinkygate was a couple of male founders who designed a pink glove that could be worn by women to remove tampons. There are so many problems that are wrong, like problems with this pitch, that women would think removing a tampon was a disgusting thing that required a glove, that they couldn't just, if they thought that way, they couldn't just use a regular glove, like a regular latex multi-glove in a pack kind of glove, as opposed to a pink one. Anyway, successfully raised funding, and not quite a sizable pre-seed round as well. And there was such outrage across the internet that they were forced to give the money back. But the fact that other people went, yeah, gosh, you're right. Removing a tampon is really a disgusting thing to be doing. This is something women need. Is probably an example of why there's a problem. I think I feel, having gone over this ground a lot of times, that having a female-oriented product and being a female founder are compounding problems more than being separate. So, for example, why do people invest in things? I think people invest in things a lot of the time because they go, God, that's really cool. Like, that's your initial response to something you want to invest in. God, that's really cool. And unless you happen to have struggled with conceiving or with your cycle for a long time, and you've been battling your vaginal microbiome in one form or another for a lot, unless you've got a vaginal microbiome to be bothered about, you're probably not, or unless you have a medical background and this is something you've studied or interacted with, you're not necessarily going to go, yeah, this is a really cool product. But it is, and it will solve problems for a lot of people. I have this, my brother actually at the moment is working on a company that's doing charging for electric vehicles, so mobile charging for electric vehicles here in the UAE. And he's in the early stages of raising funds, and everybody he speaks to had that reaction, God, that's so cool. And give him a month, they're going to be throwing money at him. So I think that's part of the problem. Is, if we're pitching to predominantly to people who are never going to think that women's health issues are cool when they're solved, then the investment isn't going to happen. And then I think, again, in terms of the metrics that we have to judge the success of companies, they potentially aren't also geared towards women at different ages and stages. For example, there's a prevailing thought system that you need a co-founder and that companies with co-founders do better. But this is predominantly based on the Silicon Valley new male graduate model, where actually co-founders do work. And there's a question: do people need co-founders? Do founders need co-founders? do companies need co-founders, or do men need co-founders? I know a lot of very successful solo female founder companies, but that's actually one of the things that if you apply for an accelerator or for funding through some of the kind of automated systems online, will filter you out immediately. If you are a solo female founder, you have to have a co-founder based on everything that we understand about tech startups using the Silicon Valley model.
Yeah, well, we've looped back around to systemic issues, haven't we? And that's the theme that's going to kind of punctuate this, I expect. I'm going to just, well, first of all, are there any questions on that sort of set of themes? Yeah, we've got one here. Let me just bring a microphone over to you.
Thank you. So not so much questions. I think I just wanted to contribute to this. My name is Mayoni Gunaratne. I'm a female founder of Human Health. So my background is medicine. I'm a doctor. I'm a former surgeon in the NHS, so very much male-dominated specialty. And I created Human Health to really help women with their health and to help them understand their current health situation and set goals and move towards that. So a couple of things. I'm a female founder. I was pitching yesterday and there was a lot of kind of glazed expressions from the male investors who were listening to this. And I had a couple of comments of, so is this about the menopause? You know, and it's kind of, no, it's this whole spectrum. Women are dominated by their hormones all of our life. And we don't understand enough about it. And when we do, we're resorting to looking at things on Google or bloggers or influencers, which is totally inappropriate. And I think to Hannah's point, I'm so excited by the work that you're doing. And I talk to patients regularly about their vaginal microbiome, and it's part of our testing. But the point is, my second point is, I don't think there's enough information out there for the general public to even ask for these things. So when I'm talking to them about their vaginal microbiome and how their hormonal status, their perimenopause is affecting that, there's a real eureka moment, and then a real kind of sensation of, right, okay, so there's some proper information out there and we're not accessing it. How do I get this information? So part of the work I'm doing is also to try and create an online education platform, which is actually doctor-led, to disseminate that information. So really, it wasn't a question. It was just to kind of say thank you, and it's great that this is even happening today. It's the first of its kind that I've ever been to. So thanks.
Thank you so much. Great feedback, and I think that's a really good sort of feedback, I suppose, from the from what's going on out there beyond this panel. Fantastic. So I'm gonna jump over to the sort of technology bit, right? So we've really got two sort of themes here. There's the founding bit, as Hannah mentioned it a moment ago. There's the founding bit, and then there's the female technology bit. And I'm going to ask Annika if you could kind of maybe talk a little bit about your experience in that space. I know when we were working on the ZSEN stuff, we kind of brought you in because we suddenly realized that when going out to visit ZSEN, you know, sitting in a room full of guys talking about female technology was not the right direction. So luckily we spotted that quite early and got you in. Do you want to tell us a bit about that, and maybe other examples, if you have them, of areas where you've added that sort of value from an advocate point of view and from a creative point of view?
Yeah. So I'm a strong advocate of the end user always. So depending on what end user it is, I think it's very important that they are being heard. So as a designer, I'm trying to make a connection between what end users' needs are and what the technology should be. And well, usually it's the other way around. A lot of technical guys or men, they are developing great stuff on a technical level. But once you are trying to match it with a human, especially with women or niche target groups, the match just doesn't exist. So for ZSEN, what we did is we interviewed 5 women, I guess, about their experience with breast self-examination. It was actually quite interesting. I interviewed both women from the Netherlands, but also from the UK. And already between those different nationalities, there is quite a bit of difference in to what level they are educated by the NHS or by their mothers or sisters about how to approach such a topic. And actually what was quite funny is that women there, well, some women, they are interested in how effective this device was in the early what's it called? Early knowing that there might be something going on inside their breast tissue. But actually for them, it was just more important that they could do it easily, quickly, without much stress. Because if you imagine you're doing self-examination in a bathroom, Saturday morning, you figure out, whoa, okay, this device is beeping orange or red. There might be something wrong. Well, the first time I can contact the GP is Monday morning. You have the whole weekend of stress ahead of you. So that's something we have to navigate as well as product designers. And I think what was quite funny actually that came about is that women actually found one of the most important criteria, that it would just fit their bathroom cabinet, rather than the stuff male technologists would expect, like, it should be this and this effective, and we want this and this of results from the device.
Thanks, Annika. I've got a question for you, Anna, in relation to this sort of man-woman tech binary. Tell me about how it works for Sensate and your take on it.
Yeah, sure. So we have actually very deliberately chosen to not use gender at all. This is a product that helps mental well-being, where actually it's more stigma for men than for women, and a lot of men sort of are not allowed to cry or talk about issues, etc., culturally. So going back to the unconscious bias. And so I think what's happening right now when we're using data for sales is that we just keep optimizing and actually segregating and discriminating more than ever, because we're sort of just blaming it on our machine learning algorithms, whereas we've really been very deliberate. And I think, you know, there's a choice to be made as well. What values do you have? Who do you want to be? It's not just what you do, but how you do it. So for us with this product, we've made a very deliberate choice that we want this product to be available. And then you have to think about not alienating also segments that maybe have quite strong gender roles and don't associate with certain words or designs, etc. So we've really tried to make it very gender neutral, and it doesn't mean that we can't have a different conversation within gender, but that's also a decision. Yeah, I think that's all I need to say about that.
Fantastic. Hannah or Sophie, do you have any experiences or thoughts around the sort of product side of things, and either how you're taking products to market or challenges that you've seen with the design of products in relation to gender and sex?
In terms of design of the product, for us at Juno, community became really, really important. And I think when you're designing a product for women or people with vaginas in particular, or around, areas that have been taboo for a long time, that sense of you're not alone and community becomes really important, and is something that we had to focus on at Juno really on and integrate into this product, which, essentially it's a test, right? But it had to be more than a test. It had to be a community, because that's what was needed. So in terms of designing the product, I think that was the biggest takeaway or learning that we had. And then in terms of getting the product in front of the people that need it, we've had a billion challenges in terms of like the kind of marketing channels that we use. And it became really obvious from day one that your standard performance channels weren't necessarily the best routes for us, because we use the word vagina very, very freely at Juno, because we are a vaginal microbiome company. But when we first put up our ads, etc., they'd be blocked by Facebook and Twitter for having that word, which is ridiculous. But it's the state and the situation that we have to navigate.
So we're back to systemic issues, right?
I believe that's what makes them systemic, Jacob. On the product side, I think one of the interesting things we had is, again, we really wanted to look at the way that healthcare works and try to deconstruct it a little bit. And then, because obviously we're focused on women, building it back up in a way that was more women friendly, which means patient centricity, which means making things a little bit more decentralized, acknowledging again that in our part of the world, primary caregivers in the first instance are majority women. So having care that comes to women as opposed to sending them and all of their dependents out to the care is really quite critical. One of the things that we found with the model that we conceptualized, and it's been picked up by the head of innovation at INSEAD, who has a couple of case studies coming out on it. We have a book contracted with Springer that is coming out early next year. It building on it, kind of integrate this integrated care model, and again, like just changing it. People didn't like the fact that we were doing this exclusively for women's health. So when we explained how our hybrid healthcare model worked, they would say, but why is it only for women? And we'd say, well, you know, that's where we see the big gap. There's a huge opportunity in emerging markets. You know, if the women's health technology market is estimated to be worth $1.186 trillion by 2027, and fewer than 1% of those target chronic diseases, fewer than 1% of those target emerging markets, and the next billion people are coming out of Africa. It's a very, very youthful, very dynamic, very innovative, very technologically savvy group that are going places quickly and leapfrogging generations of infrastructure and discovery. So you know, we see this big opportunity, and why would we look anywhere else? But they really didn't like the fact that we had said we're focusing on women's health, and then we're doing something completely new in that context that was applicable to other areas of healthcare. We got a lot of pushback on that, and I think a lot of people actually responded in quite a defensive way to it. You know, it almost worked against us that we had this new model that we were using that wasn't applicable to everybody, or that we weren't focusing on everyone at the same time.
Yeah, so I'd love to drop this like reflective notes. So I have worked before CEO as also CPO and worked with product. And one really fundamental part, or one very frequently used part of product development, is personas. And when you develop personas, you know, it's just a description. You might have a few of your typical users. And so I sort of noticed that sometimes in the personas, the female personas, would be quite sort of stereotypical and quite narrow. And I was thinking about that, and we have to ask ourselves, because we are back now to the unconscious bias. Where does that come from? And it really is storytelling. And so as a woman growing up, I was born in the 70s, you know, we watched a lot of films and content where all the main roles are male, and really profound and interesting, and you get a full complexity of the man's reality. And there's something called the Bechdel-Wallace test, which is if a film has two female roles that speak with each other about something except a man in the film, it qualifies, and only about 50% qualify. So you understand what we've grown up with. And so this has to change, right? And it's also very much because, you know, Hollywood has been very male dominated. And so we have to think about already what stories are we feeding our boys and girls, because it's not helpful for a man not to really understand women's reality. It's not helping anyone. So stereotyping and segregating doesn't serve anyone at all. And I think it's just important to really reflect now that we are in the weeds of the unconscious bias, which is extremely powerful, that we understand where that comes from.
Yeah, it's really interesting.
Yeah, and I think
Go, Sophie. Yeah.
Appreciating that things work in two directions as well. So, for example, people talk a lot now in the UAE about diversity, equity, inclusion initiatives, about making things more accessible for women, but they tend to discount the male portion of the picture. So, for example, the standard maternity leave here is 6 weeks, but the standard paternity leave first was nothing until a couple of years ago. Then it was 1 day, and I think now it's 5. But how are you going to rebalance caregiving unless you have equal parental leave, which is something that we've had in NAVTA since we were founded, but we are really in a teeny tiny minority here in the UAE. You know, if you want to change perceptions, you have to make it as easy and as comfortable for men to do all of the things that you would like women to be doing. and that includes spending time with their newborn babies, for example.
Thanks, Sophie. There's a theme around the geography as well that we touched on when we spoke recently. Have you got any other sort of insights in terms of how that looks? Because it sounds like you know quite a bit about that sort of area.
So I think if we're looking at femtech in general, again, obviously I'm a little bit biased because I'm sat out here, but I do think if we're seeing a lot of movement now in the US and Europe in terms of femtech companies that are targeting all areas of women's health. Again, if you look at big kind of problem areas that were highlighted a few years ago, everyone was talking about menopause, but there have been dozens of companies now that are springing up that are talking about menopause, and there are some really great, very public influencers. Liz Earle, who I know uses Sensate and did a post on it recently, being an example of one such influencer. But I think there's now a healthy amount of discussion going on this area as a kind of, I guess, a particular taboo or something not spoken about enough until recently. I would say that with everything where we are a little bit behind. We also have a slightly bizarre tech ecosystem, and please just interrupt me if you don't think that this is interesting or relevant. We're very much a product of a company called Rocket Internet. And when I say we, I mean the Middle East, Africa, South Asia, that was founded by 3 German brothers who built a company and sold it in 100 days. And it was a copycat of something that had been done in the US already. And they took this model and they went, okay, we're going to go to all of the countries in emerging markets where like top sort of tech solutions in the US don't exist, and we're going to roll them out at speed. And we're either going to become the market leader or we're going to be swallowed up or we're going to disappear. And so everything, I mean, people refer still to the Middle East as a bit of an ecosystem. A lot of the technology companies you see in health tech, and there are very few in femtech, but also in femtech, are copycats of things that have been done already. And yet you have an investment ecosystem that is looking for unicorns and is looking for 10x returns. And they don't understand that the reason things become unicorns is because they're doing something that has never been done before, not because they're doing something that has already been done very successfully in another part of the world. So we have a bit of an interesting ecosystem. We have one that is maybe 3 or 4 years behind Silicon Valley, that still predominantly invests into e-commerce, marketplaces, logistics, and fintech, and wants to invest in things that it's comfortable with, i.e. things that succeed in other parts of the world.
Thanks, Sophie. Are there any questions at this point from the audience on some of those themes? We started in one place and we got to another, but we covered quite a few things there, from investment through to sort of physical products and the development of those things. Are there any people who've got any experiences either working with female-based products in the market, or interacting with them, buying them, using them, or going for investment on the other theme? No. Okay. And do we have any questions from out there in the ether, or is that not a channel? No, not at the moment. If you're out there in the ether watching this live stream, please do think about participating. We're here to listen. We've got another probably another 10 minutes or so. We'll drift over a little bit if necessary, because I want to turn our attention to teams and people, and I think this kind of brings back together both the product side of things and the entrepreneurial side of things, hopefully. So I mean, at Thrive we took a conscious decision quite a long time ago to be really careful with recruitment and to make sure that we built that in. As a tech company, it's very easy to not end up with a good mix of people, and so we've really put quite a bit of effort into that. I'd love to hear your stories about how you've approached that, and I guess, Hannah, in your case, you've got a very female biased team, so you kind of flipped the thing around. Let's start with you, if you don't mind.
With me, yeah, I'm surprised that you know that, but it's true. I think that the type of people that are attracted to our mission oftentimes rather are women, are people with vaginas. And so weirdly, I guess, when we get applications, we don't see the same sort of inequality in applicants or the candidates that get through the different gates during the hiring process. But what I would like to point out, though, is that even if you're running, a female-founded company and your product is for women, it is still obviously very important to have a mix within your team of men and women, because the problems of women's health or the systemic biases that we are challenging here and trying to get rid of, that burden doesn't just and shouldn't just fall on women. It's for women and men to solve. And so yeah, we are a predominantly female team, and it's great. There is a really a sort of culture in which people just love to come to work and want to stay and grow. But equally, we're very conscious that the burden of solving these problems shouldn't just lie on women.
Absolutely, couldn't agree more. Anna, would you like to jump in with just tell us about your team?
Yeah, sure. We have a reasonably balanced team, and I've run teams in large organizations and smaller organizations as only ever in technology fields. And I think just a very short anecdote. My studies were all mathematics, physics, electronics, and computing. And there was a point when I was, 21 or something, where I really felt like quitting. And I did just at that time, it's not like, it's the paradigm and the patriarchal structures, you just don't feel like you fit in. And I went to a conference which is called Computer Girl. And for the first time in my career, I saw women in the industry who I could relate to, and I chose to stay. And that's why I graduated and had a whole career in technology, which I love. So the importance of role models and things like that are really important. And I've seen that. I left a larger company where I had a senior role, and the day I left, there were women that I've never spoken with that said, "Oh, it's so sorry you're going. We were really happy that you were in the leadership team." And so those things really matter. So I think just by gender, I would tend to have more balanced teams, and also very conscious about other hires, because it's obviously age, background, ethnicity, everything, right? It's really important. I am going to admit that when you are a startup, and with a limited resource, much easier when you have a recruiting budget, because you can go to your recruiters and say, "What is this very monoform list? Go away and bring me something better," which I've always done. Whereas very often as a startup, you recruit, you post on your LinkedIn, which is going to reflect your circles. And I have actually raised the point that this is also a real problem in the Bay Area, where the very first founders are the ones that walk away with the millions and billions. And if you just recruit the mates you went to Harvard with, then we are accumulating money very rapidly into fewer and fewer hands. So I'm very much for positive bias, because there is a huge unconscious bias going one way. If there is no counterforce, then it's not going to change. If you're doing nothing, you are just perpetuating the problem. So I'm very much for sort of biasing positively, as in two equal candidates, you choose some minority group, I guess.
Yeah, I think I agree. It's important to kind of just really hit the problem head on, and if it involves doing that, then so be it. Annika, you work with a range of different teams. You work in lots of different companies, going in and doing certain bits of work. I can sort of speak from my experience as an engineer in electronics and that kind of industry, or that kind of world. As an education, I found virtually no women in my classes when I was doing my studies, and then teaching afterwards the same. So that was 10 or 15 years ago, and it was really terrible. How has that played out, I suppose, in terms of technology development on the front line, as it were, when you're working with teams?
Yeah. So I studied in Delft, TU Delft, industrial design engineering. So in fact, I'm an engineer as well. And when I studied, I think I graduated now for 10 years ago. So also 10 years ago, it was already 50% male and female within our studies. But we were an exception within Delft University. But luckily, it also caused that most of my clients have a very diverse team, at least the ones who have people from industrial design here in the Netherlands, which I think is really nice. So on one hand, I want to go back to what Anna just said. Like, if you put out a vacancy, you will probably attract people within your network, and maybe also more male-dominant people, because they are just the ones that bring in the money. On the other hand, I'm self-employed, so I work a lot with extended teams, so the teams of my clients, or experts that I need for my work. And I think if you're very conscious about what kind of experience you want to bring on board, you can find the right people. So currently, I also have someone on my team who has actually a severe chronic disease, Duchenne muscular dystrophy, and I'm really glad he joined our team. He can only move his thumb for a little bit, so someone really needs to help him, assist him to sit in front of his laptop, start up the video call. But he's very bright, so in our conversation, I think just to have a conversation of 1 hour per week with him just adds so much more value than to have someone else with no experience with this disease not in your team. So I think diversity is not only bringing on board women or people with a different cultural background, but also bringing on board people with certain diseases or with a distance to the I'm not sure what the proper English word is. So I think that's something that you need to be cautious about, or conscious about.
Thank you, Annika. Fantastic. Sophie, could I ask you to sort of maybe talk a little bit about your team, but also about the teams you work with in the UAE and how that sort of plays out as well? Because as you mentioned, there's quite a lot of difference from Europe and where you are.
Yeah, I think that the UAE is a very diverse place, over 200 nationalities, and unlike a lot of countries in Europe, you don't really have minority populations. You have quite an even representation from many different countries around the world. It doesn't mean that people hire very diverse teams. A lot of the teams are quite homogenous, and again, I think that's due to the same kind of network effect. Actually, our team is, I think, still my proudest accomplishment. We have 57% women, 43% men. We work in 11 different countries. We have people who are still studying at university, and we have people in their 50s. Our C-suite, all of the women in our C-suite are mothers of varying ages. We all, funnily enough, have children under 5. We have, in the last 12 months, actually had our CTO and technical project manager go off. Raza is a guy, so he went on shared parental leave, and our technical project manager also went on shared parental leave. We've had 1 ectopic pregnancy. We've had 2 people trying and struggling to fall pregnant. We've had 2 women hitting perimenopause and battling, firstly not realizing it for a while, and then dealing with the challenges associated with it. We have a really beautifully diverse team. And whenever I look at our team, I think the argument again for diversity is made because everyone has a very strong opinion. Often the opinions are very different, and the way of expressing these opinions is very different. And so sometimes when people join the team for the first time, they're a little taken aback because most of our team embody Jeff Bezos's thesis about holding strong opinions weekly. They're very passionate about women's health. They're very passionate about their own experiences. And until you convince them otherwise, they will insist that this is the way things should be done. But they are also willing to communicate and collaborate, and it creates the atmosphere is a very dynamic and very open one. And yeah, I mean, they are without a doubt my proudest accomplishment. I think one of the reasons for that is because of where we are, because it attracts such a diverse group of people, but also probably because of the way that we've gone about finding people. We've never really, I don't think we've paid more than about $5 per person to recruit anybody. It's always been a LinkedIn ad for a 24-hour period. We've been quite open-ended with requirements. One of the things that we found when you're trying to hire women, and again, there's been a lot of research done on the hiring process, and is there any unconscious bias again within it? One of the things that we found is that if you make the requirements very narrow, you tend to have fewer women applying because they'll look at all of the narrow requirements and go, I don't meet every one of those, so I'm not going to apply because I won't get the job. Whereas if you keep the requirements broader, you'll get a lot of women who can then tell you very specifically what they've done against those, but they apply where ordinarily they wouldn't. So yeah, I mean, again, there's a lot of effort now. It was just announced in the UAE that it's going to be mandatory from 2022 to have at least one woman on every board. It would be nice if it was 50%, but the boards are so heavily male dominated here. Even to have one kind of mandated woman on every board will make a difference. The UAE in general has really good statistics in terms of female representation at every level of business, including in the sort of decision-making echelons. And I think they have more female ministers than just about any other country, and have a pretty even split. I always say, the Middle East, people who haven't been here can sometimes get a bit of a bad rep, but actually you'd struggle to find places that are more tolerant and open than the UAE and other countries in the GCC.
That's fascinating stuff, Sophie. Really amazing stories to hear. And I was surprised at your comment, to be honest. I thought it might be less diverse than you describe it. That's fantastic. From the floor or from the internet, are there any questions around building teams, making diversity a big issue and making it happen and sort of blazing a trail? Because clearly our panel have got lots of experience in doing that. We've got one question here.
Yeah, so I have a question to Anna and somebody else as well. So it's about investment. So question is, you guys mentioned that as a female entrepreneur, it gets difficult to find investment. But there is also a completely other story as well, where if you have a female founder, then it gets easier to get an investment. Is that true? And how are your experiences on both? Because I can talk about myself. Like, I have been investing in fertility space, and I was asked by one of the founders here in Giant, do I have a female founder? If yes, then they would consider the investment. So there is a other part as well, I suppose.
Yeah, thank you. So it's surprising that it's not showing in the numbers. It's actually less money this year that went into female-founded companies than in 2018. So it's not even going in the right direction. And so there's a lot of talk about it, and you hear this, well, it's just like, oh, well, it must be really easy. It's not showing in the numbers. I think that, what probably works is to have a token woman on board. So you got 3 guys, and then, just bring in my sister. And we've got female founder type of thing. Whereas, as I mentioned, only 2% go into female only founder, whereas 82 go into male only founder companies. So we're not really seeing that shift, unfortunately. But at least there's a conversation there.
Yeah,
Hannah,
I would suggest that.
Sorry, Sophie. Yeah. Hannah, there you go.
All sorts of excuses about. Sorry, I think there's a lag. Investors will give you all sorts of excuses if they don't want to invest in you. It's one of the lessons that you learn, especially if you pitch from a deck, which increasingly we don't. We'll share our deck and then we have a conversation. And it's very much trying to establish whether the investor is right for us as much as we being sort of appealing to them. But if an investor doesn't want to invest in you, they will give all sorts of reasons without saying upfront, I'm not interested in investing. And my gut instinct would be, given the fact that the sort of push to have co-founder teams isn't necessarily resulting in a greater proportion of funding going to them, is that is being said by investors. It's probably the sign that an investor is not interested in investing in you and they're just finding an excuse. It doesn't mean that you don't have an investable proposition. It just means that they're not the right investor.
I was just going to make another little comment here, which I would normally say, but I did recently, because I thought it should be easier to raise this round. I looked at a lot of early stage deals. Actually, I've also been consulting in venture-backed companies, and I really thought myself it's super easy to raise money given our traction and usage numbers and so on. So I spoke with a couple of more senior women, and they would never say this out loud, but they did actually say, well, Anna, why don't you pitch with your white middle-aged male CFO? Because that's what I did. Put him in front. It will be easier. So that is actually advice that behind, in one-on-one conversations. Just recently, I've got from women that are further ahead on their career. So, to your point, it's unfortunately not really where we're at. And obviously there's loads of other bias as well in terms of where the money's going. Back to my point, it's no longer the explicit excuses. No one's going to say, I don't, people generally say, I want to invest in more diverse, I just can't find them. And then they don't go into what is my unconscious bias, or what are my processes? Why am I failing myself at achieving this that I'm trying to achieve?
Yeah, great point, Hannah.
Yeah, sorry, can everyone hear me?
No.
Yeah, perfect. I was saying that I think I perhaps understood the question a little bit differently. So I understood it as, if as an entrepreneur going to a VC, if you have a female investor in that VC or a female LP, do you get better deal flow? Am I more likely to, want to pitch my company to you? And the short answer is yes. And I wonder if that was an aspect of the company, and if the rest of the panel also has a view on that.
Yeah, sure. I absolutely agree. Like, it's definitely a big issue. And just dropping some more numbers, I think it's only about 13 to 15% women partners in the US. So it's obviously highly underrepresented as well.
I think
there was a really interesting statistic that came out. I think it was even today, about the investment of founders who've achieved unicorn stages, who've become billionaires in the US. Now, there was obviously a significant disparity between male and female. I think 724 investments had been made by male investors, and there was a smaller pool from women. But of those, statistically, from the male pool of billionaire founders, 6% went to female-founded companies, and I think about 12 to 14% went to co-founded companies. And then from the female pool, 22% went to female-founded companies, and 24% went to co-founded. So immediately, the number of women represented in the founder pool more than doubled, which is indicative of the fact that if you have women who are getting to a point where they can invest, they will invest in a more even way. In fact, in an almost 50-50 way. So it's not that women are exclusively investing in women; they are investing in a much more balanced way. I think there are so many different problems, again, in terms of unconscious bias, or pools of unconscious bias within the investment ecosystem. There's the general partners who are going out and speaking to limited partners. There's the limited partners, very few of whom are women. There's the wealth and investment advisory groups that are advising these limited partners, a lot of times institutions, family offices, high net worth individuals, on investing in funds, who are almost exclusively white males. And so you've got different pools. There's also a significant lack of female angel investors in the ecosystem who are investing at women at pre-seed and seed stages. Interestingly, so we just launched a movement called 2022 Female Angels to identify and publicly list 2022 female angel investors for the Middle East and North Africa by the end of 2022. We've appointed a 30-person steerco that is 15 men and 15 women. And we are now, from the start of next year, going to be working collectively to increase substantially, and it would be a 20x increase at least, the number of female angel investors who are known to be investing in MENA, on the basis that there are many areas of the investment ecosystem that need to be addressed. This is one that we, as a group of entrepreneurs and people working in the system, can target. And so that's what we're going to do, because, again, I think, referring to a point made earlier, there seems to have been a bit of a shift in terms of the willingness to consider, to continue accepting this as the status quo. If we go backward next year, there will be uproar, there will be revolts in the streets. I think people want now to see a significant shift in favor of a more equitable system.
Completely agree, Sophie. Yeah, we have to see that positive change next year. So I'm gonna wrap things up, I think, by just dotting around the panel and just getting your conclusion, just jumping back to our kind of starting point, which was around blockers and opportunities in the space. Do you have a final thought, maybe just a quick 30 seconds on, you know, a bit of a positive take on things and where you see the challenges still lying in terms of either what you're doing or more generally, if that's more appropriate? Let's start with Hannah.
Okay. Yeah, so I mean, I love that this panel is even taking place, and it's meaningful for me because I went to Giant a couple of years ago, and you know, I didn't see a focus on the sort of problems that I wanted to see, and so I love that the discussions are happening in the UK and the US. So Juno Bio is based between London and San Francisco. We're seeing a real shift in our community of femtech founders and also in policy. In terms of focusing on women and women's health. And although there is, you know, a lot of work to be done, especially when it comes to funding, I feel like we're moving in the right direction where we are at the very least.
Fantastic. Annika?
Yeah, so personally, before this panel, it's not on my daily top of mind that I'm a female founder and that I have certain limits that I need to overcome or boundaries. So it's really good that these kind of panels are there, or these kind of discussions, that at least you know that in certain countries or certain landscapes it's a bit better than in others. That said, I think the end user of your product is always the most important one. So we should also approach these women or the users as experts, because they really are. Especially what Sophie also pointed out in being a primary caregiver, having to manage things both at work and at home. And I think those kind of insights are very, very valuable for product development. And maybe lastly, and that's maybe from a design perspective, is that women's products shouldn't all be pink. I think we should, we're beyond that phase of just adding a pink sauce on top of women's products. And we should really deeply understand what their needs are and emotions and how we should address those. And probably they are better off with something that isn't pink, but that just can fit into their bathroom cabinet really nicely.
Fantastic. Thank you, Annika. Anna?
Yeah, so I guess one sort of concluding pledge is, and it's also to the point of Annika not being pink, is that seeing everyone as individuals, and that goes for men and women. So very often it's women want this, or women drive like this, or women bosses are like this. We are not one category. We're completely different. And you know, especially in a professional environment, there's more commonality than difference. So I think we need to just really understand that it's not one big group, that we all want the same. And then I want to just give some gratitude both to the men in the audience and to Jacob, because that engagement really matters and it's really appreciated. So just, you know, it is actually sort of reasonably diverse room, and that also goes back to the point that it isn't just it's a topic for women. I do have a lot of hope in the younger generation. I see the gender roles not being so extremely strong, and it's damaging for everyone. I mean, we work with mental well-being, and the fact that men should be so tough and never fall apart and always be strong is also extremely damaging, and not developing emotional intelligence as a little boy because you're supposed to just bottle up. It actually ruins your nervous system. So we should just, you know, look at ourselves as these diverse, beautiful beings that we are on an individual level.
Well, that was a nice place to finish, but Sophie's going to get the last word.
I was just going to say, on bottling up emotion, you reminded me of a scene that plays out in our house very often between my 4.5-year-old son and my 2.5-year-old daughter. And the 2.5-year-old is a complete lunatic and winds him up no end. And she'll have done something mean, like knocked over all his leg or pulled his hair, and he'll start crying, and she'll go, "Stop crying, Oliver!" And Oliver will go, "It's okay to cry." And then we go, "Yes, Oliver, it is okay to cry. You know, Eleanor, stop being nasty to Oliver." But I think, raising children with an open mind and encouraging their curiosity and encouraging them to be who they want to be is very important. My end point actually is that if there's one takeaway from this, please understand that women's health technologies are a massive opportunity. They're a huge opportunity globally. They're possibly even from a proportionate sense of the word, even an even bigger opportunity in emerging markets. My favorite quote is from Victor Hugo, which says, "No army in the world can withstand the strength of an idea whose time has come." And I think it is Femtech's time.
Well, let's leave it at that. Fantastic. Thanks everyone for coming. And we are a little late finishing as we predicted. We'll be back here at 11:30 and it will be the AHSN and how can we support innovators in demonstrating impact in the real world. So if you fancy getting involved in that, all the speakers are very eminently connectable online. So do reach out and have a chat to them if you want to offline. I'm sure they'll be receptive. Thank you again to everyone for joining the panel today. Really great to have you. Okay, so welcome back, anyone who is here this morning, and welcome to those who have just joined us for the second session today. It's great to have everyone back on the floor and roaming around this event at Giant. It was a couple of years ago, of course, that we had a live event last with Giant, and we're back here, so that's great. Really good to see a nice full room as well, hoping that we can have lots of questions and interaction. We have an online audience who are now hopefully connected to this stream, so hopefully we'll get some connection from them as well, and questions I'm sure will be forthcoming. So without further ado, I'm going to introduce today's second session, and that is around how the AHSN, the Academic Health Science Network, can support innovators to demonstrate impact in the real world. And I'm going to introduce to you Elias Zapatas to run this session. Thank you, Elias.
Thank you so much. So hello, everyone. My name is Elias Zapatas. I'm the Deputy Head for Commercial Innovation at UCL Partners, responsible for real-world validation and technology evaluation function at UCL Partners. I'm also the sustainability lead and member of the working group of equality, diversity, and inclusion of the AHSN network. So as you can see from the slide, the AHSN network is a network of networks covering the whole of the UK. There are 15 organizations connected with the systems in place locally, trying to understand needs and priorities, and then relay them back to innovators to resolve these issues. So we are the catalyst of change. We are trying to connect partners to find the appropriate innovation to bring to the clinical practice. And we try to create the right conditions so that the innovation can generate the evidence needed to be spread and scaled up. And also we work and collaborate not only locally, but also nationally and internationally now with companies coming from abroad, trying to penetrate inside the clinical market and trying to generate the evidence in the real world. So we are here to discuss about real-world evidence. So what is real-world evidence? Real-world evidence is evidence generated in a non-controlled dynamic environment like the NHS, where many things can happen without prior knowledge. So we are trying to understand the barriers and enablers that allow this innovation to take place and also scale up and spread. We try to work with organizations in the clinical setting and generate evidence around health economics and barriers to implementation. And real-world evidence actually highlights further the value proposition of the technology, understanding the challenges that are happening in the local context. So at UCL Partners, we see actually real-world evidence generation as different pieces of the puzzle that come together to show you the fuller picture, the full impact that the innovation can have, and actually trying to generate those different tiles, as you can see here. You can have a better understanding and actually have a more informative conversation with the system. And I would like to invite on the stand Angela Ercia from CVERD. So UCL Partners and CVERD and the Northeast North Cumbria AHSN, we work together at a project to evaluate and generate real-world evidence of their CASPER system. So the CASPER system aims to digitize the referral pathway for endoscopy and trying to move from the paper-based traditional system to a system that we have increased efficiencies and supports patient and staff in doing their work. So Angela, please come forward.
Morning, everyone. Let's see. Right. So I'm here to talk about a pilot study from our experience implementing the electronic referral system for a endoscopy department at West Hertfordshire NHS Trust. And here I'll be talking about just our experience, and also how we use real-world data and how we evaluated the implementation early on, and also our early experiences working with AHSN. What did I do? Right. So this image basically shows you the complexity of making a referral for an endoscopy department at WHHT endoscopy department. As you can see, it's very complex. There's many steps involved. So for example, if you are going into your GP and you need a referral for an endoscopy procedure, your GP would have to complete a paper form in different colors based on the treatment that you need. That doctor would have to write it manually, send it to the endoscopy department for processing and analyzing and determining whether it's an appropriate referral. And then once that was vetted and it's appropriate, then it'll be given to the booking staff to book your appointment. And so as you can see in this image, it's very cumbersome, it's very complex. There's many ways that delays can happen, a lot of human error that could occur. And so that was the issue that WHHT wanted to solve, was to figure out a way how to improve this. And the way they want to improve it was to digitize the whole process. The reason why they came to Sievert is because Sievert already had a system, an electronic referral system called Casper, being used by radiotherapy and chemotherapy units across the UK. It reached about over 140,000 patients. And so they wanted to also use that software, that system into their process. Also, our Casper system was flexible enough to meet the needs of the department. And so that was the project that they wanted to pursue. In hindsight, though, there are a lot of resources and support that they needed to get this project going. And so we approached our local AHSNs. So WHHT approached UCL Partners, and we approached our Northeast and North Cumbria AHSN to basically get more support in doing this project. Luckily, they said yes. And so this partnership between different entities formed. And so the project, again, as Elias was saying, was they basically wanted to digitize the way they make referrals, vet referrals, and book the appointments. The overall aim was to develop a system, an electronic referral system. The objectives was to create the software or the electronic referral system based on what the department needed, implement the system, and also evaluate. And so, So the first step in terms of developing the system, the way we did it was we worked with the consultants, figured out what the departments needed, and then reconfigure our Casper system to make it a Casper endoscopy software for their department. The next step was to implement the system. And so the way we implemented was we basically let it run for 2 sites, Watson General Hospital and Hemel Hospital. And so we let that run. The project manager visited and talked to the staff who were doing it. And it was more of an iterative approach because we really wanted to see whether the original design was fine, was there any changes that needed, additions, or if it's a total fail. Luckily, it wasn't a total fail because it's been implemented for a couple of months now. And so this is where we started thinking about doing an evaluation. So the software has been implemented for a couple of months now, but we decided to do an early evaluation to figure out exactly how has it changed the pathway, the referral pathway and the vetting pathway and the booking pathway, how the software has changed that, what is the difference in quality of the referrals, and also just the satisfaction of the staff members using it. And so these are our early findings during the evaluation. As you can see, so I did the evaluation, and part of the evaluation was, again, trying to understand how the system has changed the workflow or the pathway of doing the referral system. And what we've noticed is that the pathway has really removed a lot of the cumbersome activities that could have produced a lot of delays and human errors based on just not having the doctors write the referral system by hand, or not having to transport the referrals to another department. So a lot of that was actually really removed by digitizing the whole process. And so we just wanted to show you how different the work path is when you digitize the referral system. So just a bit of lessons learned that we've learned throughout the process, and it's a lot longer. I just chose the top 5, but the first one is implementation is complex. So I've done a lot of implementation in public health. My background's in public health, and so I've implemented interventions, programs, and now digital health interventions in NHS. And whether you're implementing in NHS or a school or anywhere, it's very complex. There's so many unknowns that will pop up. And so you just have to roll with the punches. The other issue is that we had to embed this during the time that the paper-based approach is still being used. So we couldn't eliminate the paper-based approach entirely when we introduced this system. Second one is complex problem require complex solutions. So as I mentioned, making a referral, vetting the referral, and booking a referral is very complex. You may not think it is, but there's so many different steps. And so that require a very complex system. The third one is regular engagement with the stakeholders. So implementing any type of intervention is a very human-centric activity. And so it's really important for you to continually engage your range of stakeholders. So not just the clinicians, but also administrators or any other staff members who are part of or who are using that system needs to be engaged with it. And so having a robust way to maintain communication is important. The fourth one is evaluation provides insights and inform next steps. So evaluation, again, is really important because we've realized how our software has changed, or our electronic referral system has changed the work path or the pathway. And I just wanted to point out, since we're talking about real world data, 3 and 4 is really the areas where we were able to generate a lot of real world data to inform our development of the software, but also how we implement it. So it's really important to have that access and to use that data to continually improve the system and the way it's implemented. And last is partnering with AHSNs enabled access to resources, support, and collaboration. So at least from my experience, AHSNs has really helped us identify how do we tell the story of our experience? What type of data is useful to tell the other people, the other NHS trust, that what we're doing is useful and valuable. And also, they help us do the evaluation. They gave us some recommendations on how to evaluate things. And so it's really been useful to have AHSN as a partner with this project. And lastly, just a quick talk about our next step. This is an ongoing thing. So the first thing is we're going to continue working with our site to improve the Casper system and make sure that we meet their needs. Again, it's very complex, so there's a lot of iterative changes in that process, which is also number 2, ongoing refinement and evaluation to Casper. So while we have done an evaluation so far, we're going to continue another one because we need to figure out financially how has it been advantageous to have this. Identify other sites that could benefit this. So you could imagine other departments across the UK do need to digitize the referral system. And so that would be an opportunity for us to partner with other sites. And lastly, continue working with AHSN, because again, they have a wide network of collaborators and partners. And we definitely want to use that to our benefits to tell our story. And so one of the things that we really want to do with our evaluation is to do a case study to tell our story about the electronic referral system and how we embedded it into WHT site. Okay, thank you. So if you have any other questions, my contact is here, and have a good day. Thanks.
Thank you so much, Angelo. It was really pleasant to understand and hear about the technology of CIVER and understand actually the importance of real-world evidence, that they highlight further the complexities of the system, but also how important is the engagement with the local systems to be able to drive through innovation. And on this topic, we are going to have now on stage Nigel Harris and virtually also Louise Morper, CEO of Brain in Hand. They are going to be discussing about 2 SBRI projects they had and how these could lead to benefits out of this project. So Nigel, you can come on the stage, please.
Thanks very much, Elias. So we're based in Bristol. I head up the team that works with innovators to help them develop evidence and pull through their product or service into practice. We've got programs running around keeping people well at home, supporting young people with mental health problems, and also a new one on domiciliary care. But this morning, we're going to talk to Louise. Hi, Louise. Great to see you. How are you doing?
Hi there. I'm good.
Great. So, Brain in Hand is a really interesting name for a product. Can you tell us a little bit more about it?
Sure. So there are thousands of autistic people, neurodiverse people, people living with anxiety-based mental health difficulties who fail to reach their potential. So they might be unable to work, unable to go to college, unable to live independently. And this translates into very poor health outcomes, reduced life expectancy, high risk of suicide, high rates of unemployment. So we have developed a simple solution to help people live more independently. And we've got a pretty audacious aim. We want to transform lives, but we also want to transform the way that support is provided. So what we've developed is a combination of simple digital tools and practical human support, which is all about fostering skills in self-management. So if I was to use a fancy description, I would say we're a digital hybrid. But if I was to think of a more lay description, I think of us as a companion that's available 24/7 whenever someone needs us, designed around the user.
Right, that's great, thank you. So if it's available 24/7, then users are really going to be reliant on the app, and it's going to be a real essential support for them, isn't it? So it need to be 100% reliable. So that must have put some quite high demands, both on the development team and you in terms of evidencing reliability and effectiveness.
Yeah, absolutely. We've invested very heavily in our product and development team. When we started developing the product, the first place we looked was to the published evidence so that we could be confident that we understood what principles we were drawing, for example, from cognitive behavioral therapy, solution-focused therapy, other literature that shows how technology helps people who are neurodiverse. So that was our starting place. We wanted a product that was safe, that delivers good outcomes, that's value for money. So we're looking all the time to the evidence so that we can provide that to the people who use and purchase our system. Key to our development has been having a really strong logic model at the heart of what we do. So we're really clear about the activities that we're facilitating and how they contribute to good outcomes. And to start with, we were generating basic kind of case study evidence so that we could understand whether we were effective and whether we were reliable. And then we moved on to looking at self-reported outcomes from our users. For example, we need to understand, are our users feeling more confident about using public transport? Have they had an improved quality of life because they've been able to now get into and stay in work? And so we've moved on then from having case study, well, we've got user case study evidence, but we've also got case study evidence for our clients because we work in a public sector environment. We're working with local authorities and NHS organisations. So it's important to provide case study evidence of how we deliver value for them. So we absolutely have to understand not only user outcomes, but potential cost savings and efficiencies. And that then naturally takes us on to making sure that we have independent evidence, because we're obviously going to say that what we do is effective because we're talking to our users all the time. But we are reliant on getting good quality independent evidence. Would it be useful just to say a little bit about that, or do you want me to stop there, Nigel? I can't see you because on my screen your face is blocked out.
Oh, I see. Right. Okay. That's a shame. All right. So just talk a little bit more. You're still collecting evidence, aren't you, around effectiveness?
Absolutely.
So what sort of data are you collecting, and why are you still collecting data?
Sure. Well, when we started, we had some small independent studies. So we worked with the Holistic Society, with Devon Partnership Trust, which is a local NHS trust. And that gave us our early evidence around impact. More recently, we were fortunate to receive funding from the SBRI. We had phase 1 and phase 2 funding, which has enabled us to undertake a much larger independent study. And that's hopefully going to generate good evidence of impact and value for money. So that's in train. It's been, as everything has, affected by COVID and delayed somewhat, but we're getting there. But we don't see sort of collecting evidence as a one-off thing that you stop doing. We're constantly collecting evidence on how our users interact with our system, what the outcomes are telling us, what the cost savings are looking like. So it is certainly not just a one-off, get the evidence and stop.
Thank you. Now, how important do you think it is that evaluations are carried out independently? Because that must be a bit scary for you as a company, because obviously you don't necessarily know how the evaluation is going to turn out, do you?
Well, obviously, I mean, it's essential that we gather independent evidence, obviously, because we need to know that what we're doing is safe and works. I think it is really challenging in quite a lot of different ways, and I'm sure members of the audience have experienced this themselves. So first of all, it's costly. So being able to actually either raise funds through grants or use investment funding to pay for independent research. I think the second thing is the methodology is really challenging. We're in an unusual space. I mean, a hybrid digital solution is quite novel in the mental health space. I'm not sure that standard methodologies like randomized controlled trials are really appropriate for a technology that's kind of constantly evolving and improving. Being able to actually get the right design for an independent research study, even for example, for our user cohort, neurodiverse users, there aren't very many standardized outcome measures that are suitable or that have been tested with our user population. So are we going to be able to find an independent evaluator that has that level of expertise, who can do a robust evaluation? And I hate to say it, but pace is also an issue. In the private sector, we do need to move quickly, and a lot of independent evaluation is undertaken by academics who tend to move on a different timescale and have different drivers. So yes, independent evaluation is vital, but there are many challenges that we're still wrestling with as we embrace independent evaluation.
Yeah, thanks. So I just wanted to pick up a little bit within that. You mentioned the logic model and the challenge of finding outcome measures. And so did you have a dialogue with the evaluation partner around, what the most appropriate measures were, and sort of mutually agree what those outcomes might be?
Yeah, I mean, my background is in research, so that sort of has helped me to be able to have robust conversations with our evaluation partners. So I was able to develop the original logic model and then share it and have it scrutinized by our evaluation partners, and equally to be very robust about whether or not I thought the outcome measures that were being proposed were suitable. But it has been not in negotiation, but we have had quite a lively back and forth, because as you will know, if you get the outcome measure wrong, you may well get a false positive or a false negative. So we want to be confident that the right outcome measures are being selected.
Thank you. You mentioned that you supply both NHS and local authority customers. Do you find that they place a different emphasis on different types of evidence?
Historically, I would have said that local authorities seem to be more interested in sort of video case studies, qualitative findings, but that's really shifting. And I'd say both NHS and local authorities absolutely need robust evidence about efficiencies and savings, and are probably expecting more independent evaluation. I still think the conversations we would have with NHS organisations will move more quickly to things like the NICE digital evidence standards to understand what tier you're on. We're on tier 2, we're trying to get to tier 3. We're also finding, and this is more in NHS organisations, reference to the DTAC, the Digital Technology Assessment Criteria. We're finding that is something that commissioners are expecting us to be able to evidence compliance with as well. And that doesn't seem to yet have translated across to local authorities.
Yeah, I'm sure it will follow. Really good, thank you. So just one final question. Could you just say a little bit about how the AHSN network has helped you in this journey?
Yeah, I have to say, I know I would say this, but we've had huge help from the HSN. So first of all, when we were thinking about applying for SBRI funding, we went to our HSN partners and said, this is what we want to do. They facilitated introductions to practitioners, to researchers. When we put our application together, they reviewed it and gave feedback. They even set up a dummy panel for us so that we could do our presentation and have it sort of scrutinized and checked. So we've had really practical help from our HSN partners, and then we've had lots of introductions to people who it might be useful to connect with. So yeah, I'm very grateful for all the support we've had from a number of the HSNs across the country.
Thank you, that's really good to hear. So thanks so much for joining us this afternoon. Oh no, it's still this morning. So lovely, and look forward to seeing you again soon.
Thanks very much, it's been a pleasure.
Bye.
Thank you so much, Nigel and Louise. And as we can see from the first two presentations, innovative solutions that are proposed for challenges in the system, we can see that they need to be simple and practical in order to have traction within the clinical setting, not to over-engineer the solution there. And also the HSNs help to develop the case study with robust evidence that can actually highlight the economic implications of implementing the solution, but also the efficiencies within the system. I would like now to introduce on the stage Andrew Walker from Health Innovation Network, and we'll have virtually with us Carrie McClellan from Get You Better, where they're going to be discussing a self-management app for acute back and leg pain. So Andrew.
Thanks. I'm Andrew Walker. I head the evaluation team at the Health Innovation Network, which is the academic health science network for South London. And today I'm joined by Kerry McClelland, who is the CEO and clinical director for Get You Better. And we're going to talk about the journey that Get You Better has been on around evidence generation, how Get You Better came to work with us in South London to use the Digital Health Technology Evidence Standards Framework, the NICE framework, to map their evidence base and identify kind of where gaps were and where they might, where we with them might think about improving and developing that evidence base. I'm going to hand over to Kerry to sort of lead us in and talk about Get You Better and their journey up into the point where they started to work with us. So Kerry, please shout out when you want the slides moved on.
Thank you, Andrew. I hope you can all hear me.
Can we just have the slide?
Thank you, Andrew. And well, I'm sorry I can't be with you all today in person. My name is Dr. Kerry McClellan. I am a physiotherapist and an academic doctor. I also boundary span. I am a clinician, operate as a clinical director at Get You Better, but also have a research background. Now, musculoskeletal injuries and conditions have a huge impact on both patients, the NHS, and the workplace. They take up about 30% of all GP appointments in primary care. And there's a real need at the moment to support self-management and prevent over-treatment, which occurs in both physiotherapy, prescribing. And Get You Better provide a platform which provides digital self-management for all common musculoskeletal injuries and conditions across an integrated care system. Our platform is integrated into all parts of this system where patients make contact, GP practices, urgent care centres, physiotherapy. We work with the organisation to configure their musculoskeletal pathways for back pain, back and leg, neck, knee, shoulder, all common conditions to their local region, and then enable them to provide what is termed as a digitally enabled musculoskeletal pathway. We're a platform with a patient-focused app, and that's everything that we do, but what sits behind it is our platform and interoperability within the system. If you go on to the next slide, please, Andrew. So our aim at Get You Better is to provide true local self-management support to help patients trust their recovery and have the confidence to get better without overuse of healthcare resources. Crucially, we provide a whole pathway, local approach to self-management. Now, what this includes is safety netting, day-by-day recovery for a condition such as knee pain, back pain, referral into the system when needed, rehabilitation when needed. When patients are better, we support prevention. And really importantly, at the moment, patients are waiting longer and longer for appointments, and we provide support on a waiting list and PIFU, which is patient-initiated follow-up. So our journey to this point, and we're currently being used in 6 integrated care systems, but our journey started a couple of years ago working with the West of England Academic Health Science Network with the SBRI Healthcare. If you go on to the next slide, please. We had a platform that could deliver back and leg pain, but that didn't meet the needs of the system. And so we did a feasibility study to produce integrated self-management and prevention for multiple conditions and pathways in the health service. And this was really a feasibility study of our technology in the real world. It enabled us to do quite a lot of co-design work, both with patients, clinicians, the CCGs, the commissioners, and also work to do a full economic impact of our technology on the NHS. And that was work with the Academic Health Science Network. What came out of that with our stakeholders was a phase 2 contract with the SBRI Healthcare. And for those of you that aren't aware of the SBRI Healthcare, it is an NHS England-led contract for companies to develop technology. And it's usually led by the Academic Health Science Networks. And what the phase 2 study did, it enabled us to do 4 things. Firstly, to develop the product from the feasibility, which we co-designed, and we knew would have an economic impact from our work with the West of England Academic Health Science Network. It enabled us to continue with already deployment across a CCG, a clinical commissioning group, into 40 GP practices. But crucially, it enabled us to work with Dr. Walker and the Academic Health Science Network to do an evaluation aligned to the NICE Digital Health Technology Framework. And we started off by doing a gap analysis. We then went on to do co-design work. We incorporated behavior change. We looked at real-world data. We took and canvassed the opinions of patients and clinicians and the system, validating Get You Better, which ended up with Get You Better platform being on a case study on the NHSX digital playbooks. I'm going to hand over to Andrew now.
Thanks, Kerry. Apologies for the slides jumping. I think there must be a timer. It's not that I'm trigger happy and jumping backwards and forwards. So apologies for that. So as Kerry said, so what we wanted to do together was use the NICE Evidence Standards Framework for Digital Health Technology as a way to map out and validate what data Get You Better evidence, Get You Better already collected, as a way then to identify where their gaps might be in their evidence base, and then plan additional data collection or evidence generation. So I'm just going to briefly talk you through the NICE Evidence Standards Framework in case you're not familiar with it. So I think Louise, in the previous presentation, sort of nicely segued to it in terms of it being a good place to start in terms of your evidence, sort of your journey around evidence generation. So it was originally developed in, I think, sort of 2018, actually 19 crossover, but was updated in 2021. The framework has 3 different tiers, which cover different sort of levels of functionality within digital health tech. And within that, there are different functional classifications. I'm going to not get too techie about it, but just to sort of give you a brief run through. So basically the bottom tier, tier A, is called system impact, and essentially that's system services. So that's tech that doesn't collect data or use data specifically from patients. So an example of that might be your award sister, you need a piece of tech that helps you get your roster sorted for your service for the following week. So that's an example of how you might think about tech at that level. Tier B is where the technology is being used to for the patient to understand their condition, or as a means to communicate between the clinician and the patient. So an example might be that of video conferencing, or another example might be where data is being collected about the patient, but it's not being shared with the clinician. So it could be that they're using the app to track their own physical activity. It's for them to use, but that data isn't being shared more widely. The third tier is where there is some form of intervention. So there's actually some kind of activity within the app that is making some kind of recommendation to the user, so the clinician or sorry, the patient or the service user. So that could be linked to preventative behavior change, it could be linked to self-management, or it could be actually diagnosing or recommending treatment. Okay. So the first thing you do is when you're trying to think about this framework is to identify where the technology sits within this hierarchy. So what tier and what specific functional category does it sit within? And then basically you base your sort of mapping of evidence against that hierarchy. Okay. I think the important thing to note about this framework is that it's cumulative. So if you're sitting at the top, if your technology is a tier C technology, you have to meet all the criteria of evidence sitting below that from tier A, all the way up to tier C. It used to be tier 1 to 3, so I flip and flop between the two, apologies. It also has evidence or guidance about how you might approach doing some economic analysis linked to your particular tech as well. So thinking about the scale and scope of the tech and the potential economic impact that would have in terms of the scale of commissioning. So if there's local commissioning, the impact is quite low in terms of potential financial risk. So the needs around the evidence generation for the economic analysis is smaller. Whereas if you're looking at something that's got England-wide commissioning, then obviously you need a more robust evidence base in terms of the economic analysis. I think the key thing for the NICE frameworks is it helps you to understand what evidence you have. And I think importantly, it helps you understand what evidence you need in terms of thinking about you as the innovator, but also as the potential provider or commissioner who might want to use this technology. Oh, could we bring the slides up, please? Back button. It's back again. Thanks. So I'm going to talk about how we use the framework with Kerry and Get You Better, specifically as part of the work we did with them. So as I said, we use the NICE framework to basically map the evidence that they currently had for their technology. This to the left is, well, to your right, sorry, is a more detailed breakdown of the various different subcategories of the framework. So the different areas that you're specifically looking evidence for. The framework describes for each of these criteria what the evidence looks like. And there are different types of standard, minimum or best practice, and you rank against that. So we did that. Kerry and colleagues provide us with all the evidence they had. We did our mapping exercise, and we identified down at the bottom C that they had a gap around demonstrating effectiveness. So then following that, what we did was we worked with Kerry, other colleagues in the system to co-design a mixed methods evaluation to try to plug some of those gaps. The caveat here is we tried to do that during COVID, so it was a bit of a challenge. So there are lots of constraints that we had around doing that. But specifically, the evaluation we developed were thinking about how we could show different aspects of demonstrating effectiveness. And the NICE standards are really clear about what that is in terms of what the different elements of demonstrating effectiveness look like and the different types of methods that you might use to do that before, after, controlled studies, etc., the different types of methods that you might use. So we specifically looked at effectiveness in terms of condition-related outcomes, behavior change-related outcomes, satisfaction, both in terms of the user, the patient, with the MSK condition, but also satisfaction from a clinical perspective. You know, what did the GPs who were referring this app to patients think about whether or not it was delivering benefit for their patients, whether or not they thought it was suitable for their particular patients. So that's a quick sort of whistle-stop tour through what we did. I'm just going to now hand over back to Kerry to give you an update of sort of what the picture looks like in terms of the evidence base now for Get You Better and where they might go next.
Thank you, Andrew, very much. So following the end of the SBRI healthcare project in March, or well, actually it ended up being July this year. It enabled us as an organization, as a company, delivering digital health technology to move forwards on its evidence-based evaluation. So a certified medical device, we have a nice digital health technology evaluation at 3A. We can demonstrate behavior change of patients in our system. We have an economic evaluation that led into an ORCA app library, which is used currently as the NHS app library, at 91%, which is currently the highest scoring MSK app in the UK. And crucially, it also feeds into the digital technology assessment criteria. All of the above, including the NICE digital health technology evaluation, feeds into a sign-off for this criteria. And also the evaluation, our work with Andrew, enabled us to provide enough independent evaluation that we needed to be able to be supported and adopted by the NHS playbooks as a South West London case study nationally to reimagine, redesign pathways. Andrew, the next slide, if you could. Just very, very quickly, the kind of outcomes we were drawing from this were realizable benefits, really. Just back one, if you could. Back one, that's it. The realizable benefits that we were able to demonstrate to our customers, not the patients, to customers, were cost-benefit ratios, reduction in physiotherapy referrals, reduction in GP referrals, 50% reduction in prescriptions. We were able to say that we've asked the patients, we know from Andrew's report, from this evaluation, that it improves the confidence to self-manage, the ability to self-manage, and the understanding. And again, if you just go on to the next slide, it sounds like it's difficult. You've got some auto stuff going on there, Andrew. But if you go on to the next slide, what fed into this work, which I find really great, is that we were able to work with a university in a three-way kind of collaboration with Andrew and his team to incorporate behavior change assessment that we're doing independently with the academic health science network. What's next for us is a larger real-world evaluation of clinical effectiveness and a piece of work around digital inequality. So the next stage is a larger NIHR level type of academic research into clinical effectiveness. Thank you.
Great, thanks very much. We now need to move on, but if anyone wants to find out more about our work, both at the HIN, also with Kerry, our contact details are up there. So thanks so much for your time.
Thank you so much, Andrew. Thank you so much, Kerry. So, Andrew, I would like to welcome you back on stage. And with him, I would like to welcome also Sophie Young and Nigel Harris. And virtually, we will have Scott Cunningham. We are going to have a panel discussion now to deep dive a bit more about their advice around real-world evidence. So, Sophie, I would like to start with you. I would like to ask you to introduce yourself and also tell us more about the project around type 2 diabetes you're running, the risk stratification model, and how important is the real-world evidence generation?
Thank you. So my name's Sophie Young, and I'm one of the health research leads at Imperial College Health Partners. And we were involved in a collaborative project with My Way Digital Health, AstraZeneca, ICHT, IGHI, and North West London CCGs, which aimed to revalidate risk prediction models to prevent complications in patients with type 2 diabetes, and then link those models to tools for patients and clinicians, and then independently evaluate those tools. So there are two key areas where real-world evidence was used. So ICHP hosts the Discover dataset, which is a linked coded primary care, secondary care, community, social care, and mental health dataset, which covers over 2.5 million North West London patients. And what we aimed to do was take some models that were developed up in Scotland by with My Way Digital Health and revalidate those in the much more ethnically diverse Discover dataset. So we supported the data extraction, and also our Discover platform hosts an auto machine learning tool called Data Robot, which was used to help improve some of the model revalidation methodology as well. And then the second part in which we used real world evidence and the Discover data set was in terms of recruiting people for the evaluation, which was led by IGHI. So we host a consent to contact register, which includes patients in North West London who have consented to be contacted for research purposes and evaluations and projects such as this. And their information is linked into the Discover data set. So we recruited patients from that register to be involved in the evaluation as well.
Thank you so much. Now we turn to Scott, who is online. I would like to ask you, Scott, the work that has been done with ICHP. How did this work actually, what were the challenges that you have identified doing this work, and how the work with ICHP aim to address those and move forward?
Hi there, and thanks for the opportunity to speak to you today. So I'm Scott Cunningham. I'm one of the co-founders of MyWay Digital Health. We're a spin-out from Dundee University, where we've been developing computer services for diabetes for the NHS for over 20 years. We primarily produce patient-facing services for records access for individuals and electronic medical records, where I was the technical lead for Sky Diabetes, which is the electronic medical record for diabetes in Scotland. And I was in that position for over 15 years. More recently, we've been focusing on AI-based risk prediction models, which is why we got involved with this project. Where we actually started our journey with the AI modelling was through an Innovate UK funded project through one of their digital health technology catalyst programs. And we used that project to develop a number of literature and AI-based risk prediction models based on the national data set that we have available in Scotland. So moving on to the project that we did with North West London and funded through HDR UK and in collaboration with Sophie and colleagues, the project basically helped us to validate the models that we developed in Scotland with the much more ethnically diverse diabetes population that is available in North West London. Some of the challenges, well, I think most projects have problems with information governance, but fortunately we were able to navigate them pretty rapidly due to an existing IG framework that was in place, and we were able to adapt that to accommodate for the purposes of this project. Some of the good news that came out of it, the models performed very well in the environment with London data, which was really good to see. The feedback we received from both patients who were involved in the evaluation and the healthcare professionals, both on the display and the user experience, were all very positive. And we used that later on to help us to modify and adapt the service. There was a large number of suggestions that came out of the feedback from both the patients and the healthcare professionals that were involved, and these have all been factored in, reviewed, prioritised and factored into our development pipeline. And there were some tweaks that we made to the models, and it's basically helped us to modify and fine-tune the models that we developed in Scotland. So it's been a fantastic project to be involved with.
Thank you so much, Scott. So Nigel, now to you, and from your experience to date, I would like to ask you, what are the things that NHS is looking when conducting the real-world evidence?
Okay, thanks for that. Well, obviously, clinical benefits are sort of top of the list, and that's sort of a given, really. But then its cost benefit is still top of the list. So, and we're talking about cash releasing. So, you know, it's not just savings in staff time, which may be theoretical and, you know, may realistically not be realisable. Case studies are always useful. People love to hear a story, so I would always recommend a good case study. And then obviously, you know, the gold standard would be an at-scale independent evaluation would carry the most weight. Having said all that, we are, as we all know, living in very challenging times, and we've got major issues around elective capacity and workforce. And so we're very open to explore innovations that maybe not got such a strong evidence base, but can help with this, the challenges we're facing at the moment.
Thank you so much. So Andrew, to you now. And just Nigel mentioned about the importance of conducting independent evaluation. So I would like to ask you, what is the one piece of advice that you would like to give to innovators trying to undertake independent evaluation and identifying the right partner there?
Sure. Can I be quick and give two top tips?
You may.
It's picking up on 2 points actually that Louise raised in her talk with Nigel, and I think it's about evaluation is really expensive and time consuming, so it's being really clear about the purpose of why you're collecting evidence, and clear about the aims and objectives of that. And I would go back to the NICE evidence standards, map out where you are on your evidence journey to target specifically where the best use of that time and energy goes. So that's my first advice. And also it makes it easier from a commissioning perspective. If you're going to an independent evaluator, if you're really clear about what it is that you want to know, that's really important, because they can then come back with a clear kind of plan about the best way to approach that. The second part I would say is around choosing who is the right evaluation partner based on the type of evidence that you're trying to collect. Typically maybe two buckets. You've got people who are sitting in academic settings doing research, whereas you might have people who are research agencies, maybe HSNs perhaps, who are more in the pragmatic evaluation side, and the other pros and cons on both sides. Research, really high quality, really rigorous evidence generation, but the issue there is that the timelines for doing academic research are quite long, and academics often have different, they want different things out of it perhaps. They're looking for peer review publications as a key output, because that's what they're often kind of measured against. Whereas for an HSN, it's more pragmatic. You might, or another type of evaluation or research agency, they can turn around the evaluation perhaps in a shorter time scale, and maybe more responsive, but will be doing more pragmatic evaluation rather than research. So you need to kind of think about kind of what you're looking for.
Thank you so much. And before we close, I would like to open the floor to questions. And before doing actually that, I would like to ask how many of here from the audience have already undertaken a real world evidence or are considering. So you can raise the hands. So actually, the lady in the audience, I would like to ask, what were the challenges so far in undertaking the real world evidence?
I mean, to be fair, I'm not really sure where to start. It's been a incredibly challenging process. I think one of the biggest parts has definitely been around getting that first early adopter. Without obviously the existing evidence, it's really hard to encourage and get across the real benefits that we know that we can provide. But getting someone, particularly a customer base as the NHS, where they're even more careful with the funds that they have, they're constantly firefighting, they don't have the luxury like the private sector does to be able to think more long term. So to get someone, first of all, to just agree to be an early adopter and just to try it and see what happens, that's definitely been the biggest challenge. And then it's also around just the implementation. The teams are so busy, they've got so much other challenges themselves within the workforce. So to build a strong enough team to actually get the implementation going fast enough, that's been an incredibly big challenge that we've had to deal with. And just the data points as well, like as you've touched upon, these different evidence points can be really difficult because data across the NHS is so disjointed. So to actually get strong data out the back of it, you almost need good baseline data to start with. And that is a huge challenge to actually get. So yeah, it's been a fun journey.
Thank you so much, and apologies for taking you by surprise. So I would like to ask now the panel to reflect on what they have heard and what advice that you would like to give back to innovators that actually are going through these kind of hurdles. Anyone?
I suppose I picked up the mic first. I set myself up, didn't I? I think your experience is really normal and reflects a lot of innovators, SMEs experience. And so even though that might be slightly disheartening, it's also sort of reassuring that you're kind of you're not alone. This is normal. I think you're quite right. It's finding that first key partner. I think there is very little resource in the NHS and social care to implement additional funding. So you basically need to find a partner who wants to pull it into their service. So there's that kind of, that they're up for this, they're going to make the effort, they're going to realign resource to make this happen. And also that they want to work with you because they want to develop their evidence base too. Not just for your tech, but from their perspective, how does this tech, or often they're thinking a tech like yours. So if later down the line they go out to re-procurement, they're thinking about it could be tech agnostic, but at least they know they've got a better idea of what they might then go out to commission later when they've got some kind of evidence base. Yeah, and speak to your local HSN, I guess.
Thank you so much. Oh, Nigel.
So my top tip would be find yourself a clinical champion. So find somebody on the inside who can work with you, understands the product, and will act as a gateway or a way into your local health system.
Thank you so much. And actually, I will come to Scott now, asking how did he overcome a similar challenge? How did he overcome trying to identify the early adopter and the side that actually they were willing to work with them?
We were quite fortunate that we had a sort of long-standing arrangement with the No Diabetes service, which we've been delivering for Northwest London since 2017. So we had a good relationship with the team there within the diabetes network. So when it came to the point when we'd finished our evaluation of the service of the AI tools in Scotland, we had an interested party who were actually willing to work with us to evaluate further with, as I said, a much more diverse sort of demographic within that environment. So hence how we got involved with the project. HDR UK had funding available at the time, and it came at an opportune moment for us to actually be able to apply for that. And since this project actually happened, we've since managed to get further funding for an AI award through NIHR. So all of this ongoing evaluation has been hugely beneficial.
Thank you so much, Scott. And we can see from all the presentations that funding was an important element in order to be able to progress those studies. So I would like to ask the panel, how do you go about identifying and securing the appropriate funding? Because as we know, it's a competitive landscape. It's not always easy to conduct a study around real-world validation.
I'll pick that up first quickly. So we have a Future Challenges program, and working with our local system, we identified a number of key priorities. So keeping people well and healthy at home, young people's mental health and resilience, and now the domiciliary care workforce challenge. And we specifically allocated funding to support the evaluation of those products and work with the innovators.
Thank you so much.
So another key point, I think, is kind of highlighting the strength of your partnerships. And for example, with the Radar Catalyst project, it's very much a cross-sector partnership and collaborative project. And I think that that's something that can be very much of benefit in terms of applying for funding as well.
Scott, do you want to add anything?
Yeah, I think, again...
So I was going to say... just coming from an academic background, we've had many years of experience writing proposals, and I think there's a lot of good opportunities out there through, as I mentioned, Innovate UK, NIHR, even SBRI, the Small Business Research Initiative. They do tend to have very themed and focused topics for innovative projects, and we're always very keen on picking off every single point that they're asking for as part of any proposal that we put in. So yeah, attention to detail is essential for these sorts of folks.
Thank you. And Andrew, I noticed that you picked up the microphone. So last few words.
Yeah, it was just really quickly. So there's a big pot, SBRI going to NIHR, which, is big scale, clinical research type studies. But there are local sort of funding sources as well. So in South London, we have every year what we call the Innovation Grant. So it's between £10,000 to £30,000 to partner with a local provider or commissioner to get your kind of pilot your innovation. We also have digitalhealth.london, which we're in partnership with the 3 London HSNs, where you go onto a program. It's a competitive process, but then you have a whole package of support with navigators to help you make access to people in the system, different types of access to support around evidence generation, etc. So there are lots of different sort of avenues. So again, I'd probably say speak to your local HSN who might be able to signpost.
Thank you so much. Thank you so much, the whole panel. And before closing, just to reiterate some key elements we heard today. So it is quite important to undertake your real-world validation to identify the right independent evaluator in order to support you in this journey. And then you need to decide what kind of evaluator are you looking. Are you looking for an academic evaluator? Are you looking to have a publication coming out of it? Or are you looking for a more pragmatic approach where you want to scale up and spread your adoption as fast as possible? We also looked about the solutions, innovative solutions. They need to be practical and simple to address the clinical and local needs. Sometimes we see those solutions to be a bit over-engineered there, and actually they create more challenges than the actual problem is. And it's quite important, actually, out of the real world validation to create a case study that highlights the economic impact of your innovation. Nigel talked about cash release innovation. It's very important to differentiate what are the cash releasing evidence there and what are the efficiencies in the system. Both are important, but sometimes we see innovators that they mix those up. It's quite also important to find your clinical champion within the system. They are those people who are going to be the driving force. They are going to link with the system, and they are going to make the network, the community of practice out of which that actually will support the development of the real world evidence study, but also the further scale up and support. And lately, it's very, very important to consider the workforce implications. When we drop innovation in the clinical setting, is not only in the interaction with the rest of the infrastructure, the interoperability that we usually hear, but also we need to understand the acceptance that the staff will have, the experience that they have, and how much acceptable they are. You may have people who are more open to innovation and others who are lagging slightly behind, but you need to make sure that you're taking the whole, everyone as part of your journey, and also always consider patients. Even though your innovation may not be patient facing, absolutely will have an impact on the patient. So always having the patient outcomes at the back of your mind, the clinical impact. So I would like to thank everyone being part of the panel today and the presentations. Thank you, the audience, for being here and the online audience. And before going, I would like to ask you, if you want to find more about the HSN network, you can follow our online website, but also you can submit your innovation on the healthconnect.org.uk, where the HSNs collectively discuss about your technology, and then it's allocated to individual HSN depending on the expertise we have on the ground. So thank you so much for your time today. Thank you.
So thank you again to the panel. Fantastic, really informative, lots of information there. And like Elias says, do get in touch with them via these contact details if you want to be involved in some of the stuff that's going on and access the funding, etc. Thanks, everyone. And we're going to be jumping straight onto the next session in just a moment. We're just going to drop the feed and come back again. So stay with us or change over. Thanks again to the panel. Okay, welcome back, everyone. It's great to see lots of you here again for the third session today, the final session before we take some lunch here at the second day of the Giant Health Show. So we've got a really interesting talk coming up next in and around the world of IP, and specifically around artificial intelligence and IP. So take a hard problem and make it harder is how I see that. I'm going to introduce directly to the stage now Carl Barnfather from Withering Rogers LLP. There you go. Sorry, it's on the screen. Welcome, Carl, and thanks for coming.
Hello, everybody. So yeah, I'm Carl. Withering Rogers. We're one of the larger European patent and trademark firms based here in London, as well as elsewhere, Munich and Paris, among other famous cities like Leamington Spa, for example. Over 200 odd people. I'm one of the sort of long-standing. Is that better? I'm one of the long-standing members of the electronics and computing team, which has over 40 patent attorneys throughout the firm. And my own group focuses particularly on software. And of course, having worked in software innovation for some 20 odd years, we've developed into AI in the last 5 or 6 years, not least with two of my colleagues having done PhDs in the intersection of optics in one case and stem cell technology using AI to determine viability of stem cells, and in cleft palate diagnosis imaging. So two of our guys have got PhDs in this sector. The rest of us have come from a background of software innovation and protecting it. I thought I'd start with a bit of an overview of what intellectual property is, so that we've got a bit of a common ground, and think about strategies of using all of those different types of IP, for then going on to concentrating on AI in the healthcare and health tech sectors, and thinking about the taxonomy of AI in particular, because it does break down quite nicely into different areas which lend themselves then to different forms of intellectual property. We'll then focus on patents, with a view really to considering the dichotomy that is whether you patent or whether you keep something as a trade secret, which is the big, most prevalent thing that's different in AI technology and innovation compared to other areas of technology. So we'll give that some consideration at the end. So hopefully it'll come together, as I say, with some basic introduction to IP and taxonomy and machine learning, but then focusing on AI and patents and trade secrets. So intellectual property is an umbrella term. All good companies will have a full IP strategy, not just thinking about patents, but having a good method of keeping their copyright materials recorded, authored, marked appropriately, and so on. Have we, in the audience, have we got a general understanding of intellectual property, the umbrella term, the different types, registered designs, and so on? Okay, so I won't dwell too long on that. But suffice to say, it really is important that that a company has an IP strategy that's commensurate with its own business objectives, that uses all manner of trademarks, registered designs, and so on to meet those business ends, including a lot of contractual relationships and licensing and so on. So, and then we'll come on to consider, the patent trade secret dichotomy in AI. So, categorizing machine learning. It is it's useful to think about. It's just not one thing that's patentable. There are many integers within a machine learning stack that lend themselves to different types of intellectual property. So I got a universal nod to knowing what IP was. Data. What sort of IP would be attracted by our data and our data sets, our databases? Do we know? Anybody prepared to raise the hand or just gush forth with some font of wisdom? Yeah, good. So that's this bit up here. Oh, sorry, I'm not doing this well at all. I'm used to doing. Right. So that was my summary. I'm looking at slides which I thought were reflected behind me. Now, -0, -1 point for everybody for not pointing out that I wasn't speaking to the right slide. So that was what I was talking to a minute ago. I'm now talking, and then I was talking to that side. Honestly, I'm about 3 slides behind. Hopeless. machine learning. And there we are.
There we are. Okay. I'm in the way a bit. So I'm talking about this top left part of this taxonomy. So I've broken down the machine learning stack, as I said. So focusing on the top left here, I'll go through all the integers and so we'll get a good feel for it over the next few minutes. It's been suggested that the methodology of processing the data might attract some form of intellectual property. What type of intellectual property would that be then? Yeah, which might then be a trade secret if we elevate it to the right level of secrecy and so on and protect it well. But absolutely right. So my question fundamentally was about this top left thing here. This is your database, and it actually attracts a right in its own, a sui generis right called a database right. And that's the mere aggregation of data attracts a form of protection in many countries, and it's worth knowing that. It's worth keeping that catalogued and appreciating that, you know, that is something which is licensable to attract royalties, and you know, it's protected in law. That mere aggregation of all your, you know, healthcare data about multiple patients and so on. The thing that the NHS is much criticised for letting go cheaply. Then on the top left here, we have actually got some kind of pre-processing of data, supplementing, filtering of data, which could attract patents, for example, or trade secrets. The code, the software that does that would attract copyright in the code itself, and the process, the software, the function of the software can attract patents. I think something that's fundamental to all of this, and it sounds like we've got a reasonably good understanding of IP in the audience, software is patentable. Let's dispel that myth right at the beginning, and hence the software, the algorithms, and so on, and that use of that that functionality is patentable in the AI sector too, and it's well established now at the European Patent Office, for example, which establishes the highest hurdle for patentability of software-related inventions, that AI pretty much follows the same thing. And we're going to come on and look at where the discrepancies might be compared to other technologies later on in the talk. So continuing with this taxonomy, the categorization, we've got the top left here, we've got data management, algorithms, filtering, coming into the training methodology, which sits on a hardware platform, all the NVIDIA GPUs that everyone's using these days. We're using core algorithms for processing within this whatever kind of stack we've got in a neural network, then to establish a trained model. Anybody else want to let us know what sort of IP might be being attracted amongst those different sectors of the ML stack? Give you a big hint in relation to patents and trade secrets. Anything else? Yet again, the full gamut works really. You know, you've got some copyright in the algorithms, in the coding you're using, the code that you develop to do this stuff. Patents in particular is quite a fundamental area on platform electronics configurations, novel and inventive platforms you might be using. So again, the whole gamut really applies through to this trained model that we established in machine learning, which then gets put onto something which the user gets to see in some form of application, however that might be in your model, whether it's you know, an actual mobile device that a standard user uses, or a user interface on your you know, however it might be to interact with your customers ultimately. And eventually we get this improved models, and what we see is, and that front end, that application end, is pretty much the area that I've been working in for some 20 odd years now, not least the likes of people like Apple with their iPhone and the user interfaces and the software that they use, and that's intrinsically patentable stuff. And of course it's highly patentable because it's stuff that goes into the public domain, and so therefore a strong patent program for that stuff is important, because otherwise you're going to lose the intellectual property. Hence, you know, we've got all the phone wars and so on, with many thousands, in fact, patents per mobile device being in existence. So that's fairly straightforward. That's the application, that's the front end, that's what sits in the public space, and therefore is reverse engineerable, and potentially they're going to be infringed if you don't get the right protection. So I should have some animations. to then start thinking about. So there's basically a big divide here between what goes into the public domain on the right-hand side, and then really what sits behind firewalls and what have you. And that's the dichotomy. That's where we get this fundamental difference between all this innovation that I do for lots of tech clients that is on that right-hand side, that's public domain. It's a simple question of economics, ROI. Is it worth patenting? Yes or no? Is it going to be valuable for someone to infringe? Can we license this stuff, etc.? Normal IP strategy considerations. Now in the background here, sitting behind this firewall, we have all the stuff that you potentially isn't going to be reverse engineerable. People aren't going to be able to find it out, potentially. I mean, some of it can be still, depending, they play with your device sitting on your server, and you give them the opportunity to put lots of inputs in and look at the outputs. They might be able to reverse engineer it, but potentially you've got something which is then more likely to be, or possibly better protected through trade secrets. So moving on then, just thinking about patents. Here's some data just to show you the overall filing of patents at the European Patent Office for the last 10 years or so. And this is by country of origin. So the EPC, the European Patent Convention, 38 member states, down the bottom left there in blue, are the highest filers at the European Patent Office. And these are patent applications covering those 38 member states. This is a non-EU body, thankfully, for those European patent attorneys based in Britain. Now we're outside the EU. Then we've got some 44,000. So the second highest origin of patents in the European Patent Office is from the United States, and so on down. And we're just going to see what sort of levels of filings those countries of origins have in relation to medical technology at the European Patent Office. So Europe's filing 5,000 or so, 5,400, which approximately equates to 12% of its filings. Just check my data. Sorry, it's actually 7%. So 5,400 of the 44,000 I mentioned earlier, 84,000 I mentioned earlier. Whereas the USA, who's got a comparable number of 5,000 or so medical technology patent applications, but far fewer overall. So it's a much higher. So you can see just from the data that it's a very data-rich sector, and it gives us lots of intelligence about who's doing what in the medical technologies patent space. And so we see that the Americans are fact filing about 12% of all their European applications in medical technologies, with the other countries, China, Korea, and Japan. These are the top 5 patent countries, by the way, filing about 4% of their applications in medtech. In terms of medtech and AI, sorry, AI first. I think I could show you lots of drawings showing you how AI filings have gone up tremendously in recent years. According to this Statista website, 2021, there were 279,000 patents from US companies in the AI sector. Sorry, this isn't for medical applications, it's purely AI. And then Europe somehow is distinguished from Germany, UK, Spain, Sweden, Switzerland, and Austria. So I don't quite know what they're talking about there with their 60,000. But just to show you the sorts of rough numbers, USA is well out in the front. I assume Europe is the rest of Europe. I couldn't find it on the website, but Germany and the UK pretty strong there by comparison. And like I say, I could have shown you an awful lot of data. But just to show you that AI patents and medtech is a strong sector, and thank you for your interest in the talk today. Top left, number of medical artificial intelligence patent applications by office. So most filings are happening in the United States. That's from any origin, any company, any country. Second preferred destinations: China, Japan, Korea, and then Canada. And Europe and EPO doesn't make that chart for some reason. On the right, number of medical artificial intelligence patent applications by applicant company, with when that data was collected, University of California ranking #1, and you've got the by year and the recent. So that's an infographic showing the recent increases. Then finally, who's filing where, from where. And one thing of concern, I think, in Europe is that the domestic applications, if you can just see it down the bottom left here, actually overall relatively low compared to foreign filings coming in. Now, as I say, America filing 12% of all of its patent applications in medtech. Canada being a very favoured country to seek protection in for various reasons, and Israel down the bottom right there. So again, very, very data rich. If there's anything you specifically would like to know, we can go away and do searches and give you much more intelligence on that. So a very vibrant area, and not surprisingly. And now then, thinking about what's actually happening to those patent applications, how are they different? What is there any real disadvantage to seeking patents for AI? Over and above that dichotomy with, well, I could keep it secret. So we've analysed over 3,000 published European patent applications by all applicants, and as I said earlier, in fact, software innovation, AI fits well and truly within the realm of software innovation, and it needs to meet the fundamental requirements of all software patent applications at the European Patent Office to get a patent. So one of the fundamental requirements is you disclose the invention fully and completely so that a skilled person can replicate your idea. That's been fundamental to the contract of patents since the year dot. And then over and above that, you have to have something clearly which is new and inventive. And the European Patent Office in software innovation established very early on a requirement that as long as you've got technical character, as long as you give your software is actually on some kind of technical platform, a computer, a processor with memory and so on, that meets that hurdle. You've got some technical character. And then are you technically innovative, which could be summarized as, does your invention solve a technical problem with a technical solution inventively? So in other words, not in a non-trivial or obvious manner. And the same rules apply in AI. Okay, so full disclosure, your patent relates to something which is on a technical platform, and it's novel and inventive. So looking, I'm pretty hopeless, I'm afraid, with this zapper, aren't I? So then we looked at those that taxonomy that I showed you earlier, just to break down machine learning in particular and give it some focus. And we thought, well, what percentage of applications are being filed in data management, core algorithm, training process, hardware, and applications? Now, unsurprisingly, applications comes out number one, but it only has 49% of all AI applications. So, and that, frankly, when we first worked that out, was something of a surprise. Because of this dichotomy, why wouldn't people be keeping more trade secrets? And they're not, and there are many, many reasons why not. Not least the difficulties with keeping trade secrets secret. Ideas can walk, staff walk. It's very hard to enforce contracts of employment and confidentiality. It's possibly going to be something which is more prevalent. I don't know if everybody's aware of the Waymo Uber decision in America recently, the last couple of years, where directors from Waymo got hired and subsequently took trade secrets with him, was found in court for taking trade secrets, and Waymo was fined something like $250 million US, breach of trade secret. Uber, sorry, was fined for breach of Waymo's trade secrets, and the director was actually given a 4-month custodial prison sentence. And that isn't possible in America. We don't have that in Europe, but we have similar, very strong trade secret protection in Europe, and so it might be something we start to see much more of in this AI sector, use of trade secrets. But certainly, it was somewhat of a surprise that it's only 49% of patents in AI related to the application, the front end, the public stuff, and as I say, 51% therefore relates to the other parts of the ML stack. Then we thought, well, what? So the EPO is very good at telling us, the European Patent Office, that it's the same as software, and that you can get patents for AI, and that's all very good. But we thought, well, let's do some analysis, and we've analysed over 6,000 office actions at the European Patent Office, and we found that, and you get a lot of box ticking in your office actions, if those of you familiar with patent prosecution at the European Patent Office and other offices, where they like to raise a thing called a clarity objection, some words if they find a little bit confusing or something. And certainly they like to raise some objections to show they've been doing their job. And in over 59% of cases, we've got objections related to the lack of inventiveness. This is that final criteria that I mentioned earlier. So you've disclosed your invention, you've got novelty, but they're saying, we think you lack inventive. It's not that clever an idea. You can't have a patent. So that's 59%, sorry, of cases in inventive step under Article 56 of the European Patents Convention. Now, of all of this data here, the one thing that stands out is that 10% of AI applications lack sufficiency of disclosure. Okay, so what the European Patent Office said, we don't think you described this invention fully enough for a skilled developer actually to reproduce your idea. You've not told us how it works properly. And that is not common. In all software cases I handle, I mean, I rarely get a lack of sufficiency objection. So maybe 1% of my cases normally, but in AI, we've seen across these 6,000 examination reports attracting approximately 10% of objections. And when we analyze the data, sorry, doing the wrong one. When we analyze the data a bit more, when we pair up where the technology is, whether the patent application is seeking to protect the application and all the data management, we find that the peaks really do come around the data management alignment with in these top rows here, first three, and then the last three, again being paired up applications related to the application with the other two areas. So what's going on there? What we found is, give me a second. So there you go, that's highlighting where the real problems are. In particular, there was one other on the far left, which is data management itself. But these five peaks of this lack of sufficiency is where there's an application involved. And what seems to be the case, possibly naivety on the part of the drafter, the patent draft person, in this relatively new area of tech, putting this together and saying, for example, in this where they're claiming processing the first temporal sequence of health events using a recurrent neural network, the patent office simply said, well, you've not described the architecture parameters of the recurrent neural network. It's too much trial and error to expect a skilled person to go away and develop that without further information. You can't have a patent. This is pending appeal, this particular case to Hitachi at the moment. So, consequence of that is, in machine learning, you do need, because it's a high level of rejection, 10%, to consider this stack. And I think the problem is people haven't been considering this. They've simply been hand-waving to the background, to the structure, in that when they draft the application, focusing on the application and simply saying, oh, we used a machine learning stack in the background to do it. Okay, not good enough. Provide information. So some useful hints as developers, hopefully most of you in the audience, of AI innovation. Apologies. So again, all that stack, and different parts of the different areas of the machine learning structure. You want to be thinking about this sort of thing: cardinality and dimensionality of the training data. Provide maybe one example, if possible, of the data, what it looks like, what the fields are, etc. Which algorithms were used? Naive Bayes, for example. How were the hyperparameters determined, and so on. So some hints there, and also the way you describe it. Then, break down the actual ML stack with functional units and describe inputs and outputs. Again, just one example of how the overall architecture works, and you come up with your model that then actually finds that real life application. So not good enough to simply point to the background. So that was that. That was that picture I was talking to. So some considerations then, drawing to a close. I think I'm getting there, aren't I? A few minutes before your lunch. So AI, no different to any other form of technology and development, have a strong IP policy, include all forms of IP, registered trademarks, designs wherever possible. That's possible for graphical icons, for example, in user interfaces. Copyright, authorship, contracts of employment, third-party licenses, know what deals you're in, who your deals are with, what they're worth. And then we got this thing about, do we keep something as a trade secret? More prevalent in AI because a lot of what you've developed will sit behind firewalls. It's possible to keep it trade secret, but you've got to do that with significant effort. You have got to keep it secret. You've got to limit the number of people that have got access to it. Ideally, you keep a metadata database of those trade secrets. You know who's got access, where it's saved. So the database itself doesn't contain the trade secrets, but it's got all the information related to it. Who's licensed under it, for example? Has it gone out to third parties? Who's monitoring that use of that third party? So you need to police your own. You need to have a policy that's in place to guard those trade secrets. And so it can be quite significant. To take that step to think about using trade secrets much more than traditional patents. But patents are possible, and we've seen that 51% of patents behind the firewall of all applications, the European Patent Office, were for innovations behind the firewall, and for various reasons. Potentially academic interest, PR. It's good to get a published academic paper out for some companies. If you're going to put it in the public domain anyway, file a patent application before that. And then finally, literally my last slide. Oops, on my computer, but not your screen. To get better familiar with this, and I thought about trying to do this here, but it's just a bit of an ask. We run war games workshops, interactive workshops, where we create teams of participants representing anything from Mega, I think DeepMind Health, with its AI platform, its massive database, which is then interacting with its own customer base, customer layer down here, healthcare providers, patients down the bottom left, and then 3 startups, 3 innovative companies in Alpha, Bravo, and Charlie, all of whom have got different IP policies. And we basically run through a series of stages in a war game and see how all 4 of those companies develop. And you are the board, you are the chief intellectual property officer of those different companies. And we find it's good fun to run. People get a lot out of it using that mix of intellectual property. And so there we are. If you're interested in that, do get in touch. There's my email address. We're on stand E2, shoes with me. And we'll be there this afternoon. If you would like to come and have a chat, we'd love to see you. Have we got time for questions?
Thank you for excellent presentation. You mentioned a lot about patents, but what about, so you mentioned about whether it's a better idea to do a trade secret or filing a patent. But what about if we file a patent, we are exposing it to so many other people. So how do we find out who is infringing, and how do we protect our ideas more than?
And that's a big consideration. Absolutely. So that is the bit that's. So we've actually developed a tool to help clients work this out. That's one of about, we think, 15 primary considerations. The extent to which you can discover infringement. That helps you think on balance, do we go for trade secrets or patents? So it's not a simple one to answer, and it's about your policy. Are you going to put people out there policing? Are you happy to have them there defensively to cross-license if you're sued, or are you going to go out assertively? So it depends on your policy. You need to know firmly as a company what your stand's going to be. So, for example, detection, key point, can you then afford to litigate anyway? So insurance might form part of your policy. A £20,000 a year premium giving you £500,000 worth of IP litigation insurance, funds is another big factor for you. So it's all about your policy, and it's fair to say I think it would be sensible. I mean, it sounds self-serving, but genuinely I think because of the difficulty with trade secrets, keeping them trade secrets, a mixed portfolio with at least some, might only in some instances be 20% of innovations patents, 80% trade secrets. But there are significant risks with trade secrets. Actually keeping them secret, not letting them walk with people, etc., is your real problem. So it's a balance.
I have another question here. We've got 2 more questions, 1, 2, and then we're going to go for lunch. So
yes,
more for you, Carl.
sorry.
Carl, thank you very much. Excellent presentation. Really
Thank you.
enjoyed it. Carl, I've got a question. If I go off piece, just let me know. This is a question about an idea for an AI innovative product or device.
You're not going to tell us what the idea is, are you?
I'm not going to say the idea, but actually I don't have one, but I'm just hypothetically speaking, if I have a great idea, but I'm not in a position to develop this, but I want to try and protect my idea so that when I do get the funding available in 5 years' time, I can then develop my product or idea or innovation. Is the idea itself capable of being protected? And if so, how does one go about doing it?
So if you keep it as a trade secret, then ideally there's a thing called a black box disclosure. So if you demonstrate the functionality of it, and that demonstration doesn't give away the trade secret, doesn't give away what it is you're doing inside your so-called black box, then maintaining it as a trade secret throughout that 5-year or whatever it was, development stage, then that's what you've done. You've kept a trade secret. So trade secrets are, there for you intrinsically as a company yourselves to manage. You don't register them as such. Like I said, if you've got a series of trade secrets, and there might be a stack of little ideas that form different trade secrets. And not just one idea, and so keep a database of metadata related to each of those ideas, and that is it. Keep them secure, limit the access to them, and that would be the way to go. I think so.
Okay, so patents rapidly become very expensive indeed.
Yep.
So what's the strategy? I mean, you've got UK filing, then Europe, US. I mean, a small company is not, will not be able to afford to get full coverage. So what would you recommend if they're going to go and talk to a big player, but they want to put something in place? What should they do?
Yeah, I mean, it's a perennial problem. So PCT gives you 30 months, 2.5 years from priority. Not really that long, but that's a way of keeping costs down for a period of time. But it's a cost deferment exercise, as you're obviously aware. Ultimately, Europe and USA would be biggest bangs for bucks. You've got getting on for 50% of the world economy just with those two regions. You've got 5 or 6 years of prosecution before you then get the significant costs potentially of translations and so on, which of course aren't that big a deal these days in Europe, following the London Agreement, and so English suffices in many countries. So it's no longer Europe and USA would be a fair strategy for most companies alone, and then you're talking what 30-40 grand maybe to get a good coverage over the 5 or 6 years from drafting through to grant. Under 50 grand, I would imagine, on most cases. It's expensive, but compared to marketing budgets, R&D budgets, and the protection you get, the value is potentially there, isn't it? But then, of course, you want a portfolio, so you want several of those things. So funding is I'm afraid, key.
Sounds like we go back to patent strategy at that point.
Exactly.
Fantastic. Well, thanks very much, Carl Barnfather, for your presentation, and great speech with you.
Thank you all very much.
So just a bit of housekeeping. We will be back here at 2:30 for a keynote discussing the generating real-world evidence at scale using advanced analytics. So feeding in nicely to what's been discussed potentially here. Hopefully you'll have a nice lunch and we'll welcome you back shortly. Well, good afternoon, everyone. Thanks for coming to this session, first session this afternoon, the final quarter of Giant Health 2021. Great to have you back. And we have 3 items this afternoon. Firstly, 2 presentations from our friends at McKinsey, and they'll be pre-recorded sessions, so we'll be able to see those online and in this auditorium now. And then we'll be doing a panel discussion at about 3:30, where I'll be bringing some fantastic speakers together, Zeke being one of them, who's in the audience here now, and we'll be discussing age-related tech. So without further ado, I will jump to the beginning of this session, just introduce Thrive and what we do. We're looking after this session today. So we are a team specializing in the development of wearable technology, and we specifically have a mission to work on technologies that have disruptive impact in the health and wellness space. So we look to work with teams across 3 sort of major dimensions. I'll just jump forward to that. So physical device development, and then we work on interfaces and the digital side of things, creating ways of looking at that information. And to tie it all together, we do some data science, specifically in relation to creating algorithms on wearable technology, in order to pre-process and pre-filter that data that's coming from the wearable devices. So we bring this proposition together to work with either startups, scale-ups, VC-backed teams working in wearables, wanting to be in wearable technology. Or we also work with sort of larger SMEs wanting to break into wearable tech or create health tech innovations and products. And we work as a sort of technical team to support those activities. We have a fairly, I won't go into the case studies right now, sorry. We have a fairly extensive geographical footprint. So we work all over the place, lots of different companies, and more than happy to talk to anyone at this event who's looking to get into wearables or take a wearable to market. My team are situated. Further ado, I'm going to introduce our first session of this afternoon, and this is a keynote address entitled Generating Real-World Evidence at Scale Using Advanced Analytics, and this is a presentation by Chris Anagnostopoulos from McKinsey & Company. If you could roll the video, gents. Thank you very much.
Me too. It's a delight to be here and a great honor. I'm Chris. I'm a senior expert at McKinsey. I'm focused on the safe adoption of artificial intelligence and machine learning in the life sciences, and in particular, evidence generation by the fusion of real-world data with other sources of evidence. My background is in large part academic, having been an associate professor at Imperial College, and I bring in a statistical mindset to my work, thinking a lot about what needs to be in place in terms of guardrails to ensure that insights extracted from machine learning models are reliable and actionable.
So we're very excited to talk today about the topic of next generation real-world evidence analytics. And today we wanted to cover 3 topics. First of all, what do we mean when we say next generation real-world evidence, and what actually value does that create for life sciences companies? The second is, how does one know when it makes sense to leverage next generation real-world evidence? And how do you industrialize this? How do you do this and capture value from it at scale? And before we dive into what we mean by next generation real-world evidence, it's worth potentially taking a step back and looking at the trends that we all acknowledge are happening that are driving really strong interest in real-world evidence over the last kind of several years. And much of what's on the slide could have been said several years ago. The trends driving use and acceptance of evidence beyond clinical trials are well known and have been in place for a while in terms of acceptance from various regulatory bodies, healthcare professionals and healthcare stakeholder acceptance and demand for data beyond clinical trials, and the growth in data that can be leveraged and analytical methods that can be deployed real-world outcomes, patient centricity, and value-based care. I think what's different and what's exciting is that we're beginning to see industry players in life sciences capture really transformative value from this, from indication finding to regulatory approval support to value creation for on-market assets. There are now more and more tangible examples of how real-world evidence can create value. And we see that pharma companies, for the most part, are capturing this value at scale. We see a lot in oncology and rare disease, label approvals, and some really transformative examples in other therapeutic areas as well. And what we get excited about also is that the blueprint for success, what it takes to capture this value, is becoming clearer and clearer. From the strategy that's required to the organization, to the capabilities and the underlying tools. And we see that a very large proportion of companies, 80%, have established evidence-wide, enterprise-wide integrated evidence generation planning to allow them to do this across the entire value chain. And some examples, we see that if we look across life sciences, pharma companies have traditionally been the tip of the spear, as it were, in capturing value from real-world evidence, and it's slightly less tapped into in other areas like diagnostics and medtech. But we see in R&D from using novel endpoints in clinical trial, from using omics data to identify variants, this can have a significant impact in terms of the pace and the rigor at which people are able to identify new indications for products and inform trial design. We see that in market access, there's significant reimbursement support that can come from real-world evidence. We see a lot of potential for health economic impact, and even in medtech here, some indication expansion outside of clinical trials. And then in the post-commercialization stages, see that enabling evidence to be published that can inform decision-making, to demonstrate improved outcomes in particular therapies, and to identify a broader range of patients who might benefit from the adequate therapy, and to address evidence gaps for an asset at much greater pace and reduce cost. And this is in part enabled, as I alluded to, by burgeoning in the sources of data that are available. And on this chart, we talk a bit about data richness and completeness, of which the clinical trial obviously is the classical go-to. But when looking at real-world data sources, labs, claims, EMR, they have significantly more breadth in terms of what could be tapped into. And when we talk about other less conventionally used sources like unstructured imaging data, transcriptomics, proteomics, social media data, and doctor's notes, there's a treasure trove in there, but it's difficult to get at. And on the chart, what we call this data engineering effort is a reflection of how clean is that data, how much work does it need to extract those insights. And in a sense, that's a trade-off that we're seeing is very real in terms of working with the real-world data to get access to that breadth often requires significant uptick in the analytical methods that are deployed. And Chris will talk a little bit about what those methods are.
Thanks very much, Alex. I think it's always difficult to classify analytical methods into sort of mutually exclusive groups, but we're making an attempt here to think of them as falling in one of three categories. In descriptive statistics, the purpose is primarily to just explore the data, identify interesting patterns, without necessarily building in any assumptions or trying to test any assumptions, and certainly not trying to predict what happens out of the training sample. In contrast, in classical statistics, and by the term classical here, we mean established methods for statistical analysis of medical and life sciences data, the main objective is explanatory. So there is either an existing hypothesis to be tested, or perhaps there's an intention to test which hypothesis is the most likely among several. At the end of the spectrum, we have advanced analytics, where primarily the technique is designed to predict, to have very high predictive accuracy out of samples. So the main focus is generalizability, and at the same time, by utilizing modern compute and novel algorithms, it can actually absorb and ingest vast amounts of data that classical methods or descriptive stats couldn't possibly scale to. So with that distinction in mind, we can then go through a number of different axes and see what is the current, if you like, standard in the industry along each of those dimensions with respect to that distinction, and where could we get to in the future. Starting with data, in general, descriptive statistics offer very targeted analysis of just the very high-level main features of the population of interest, like the outcome or the basic demographics. With classical statistics, we can get to an investigation of a limited set of variables, like, for example, basic phenotypes or basic demographics, and try to understand how these predict or relate with the outcome of interest. So the choice of variables to focus on is very much driven by medical expertise there. In advanced analytics, instead, the algorithms and the compute is set up in a way that can ingest thousands of variables from structured or even unstructured data increasingly. We see the industry positioned quite squarely in the classical statistics, if you like, comfort zone when it comes to the amounts of data that are ingested on a day-to-day basis in this space. When it comes to accuracy and bias control, descriptive statistics is not designed to offer either of those, and therefore it's kind of out of scope. But in classical statistics, bias reduction is a very core consideration, and there is very long established techniques for reducing bias, either through population refinement or matching. However, generally speaking, there is an over-reliance on linearity and other simplifying assumptions, and these are sort of traditionally coming from computational restrictions that are no longer in place. So we could see a path towards techniques that achieve bias control via increased reliance on nonlinear, very flexible methods that might be computationally intensive, but it's an amount of computation that we can now easily handle. So that's an ongoing journey along that dimension. An important consideration is causality. So obviously causality is the holy grail, not just in the life sciences, but in any scientific discipline. And without randomization, so in the absence of randomized clinical trial, there are certain techniques that we can use to get us closer to causal inference, but they're very challenging and they need to be employed with care. And therefore, the industry is currently relatively cautious when it comes to attempting to do causal inference on data that is not perfectly randomized in a double-blind setting. At the same time, very persistent correlations after correcting for certain propensity to treat or other types of bias and selection mechanism correction, they can appear as hypotheses that can then be further validated in future experiments. When it comes to advanced analytics in causal inference, there's a flurry of interest right now in combining techniques from machine learning with biostatistical methods for estimating outcomes and effects to achieve a causal inference framework that is much more generic. For example, using conditional independence assumptions in probabilistic graph models across hundreds of variables. So that, again, is an evolving space, but one that is still seeing a growing but modest adoption in the industry. When it comes to insight generation, it's pretty clear that it's tied to the amount of data that can be ingested to a large extent. Descriptive statistics is largely manual, whereas in classical statistics, we can have confirmation or even validation under certain conditions of largely pre-existing hypotheses. Whereas in contrast, with advanced analytics, we can get to automated discovery of insights from very large sets of variables. Again, the industry is positioned in the neighborhood of the classical methodology in that regard. And finally, industrialization is linked to the above point as well. The extent to which you can repeat an analysis, refresh it with new data, or extend it to similar use cases is a main driver of the speed of insight generation. And there, although we've seen widespread industrialization of business intelligence dashboards and basic descriptive stats, most classical analysis remain one-off exercises, and that's primarily because of the reliance on manual steps. Whereas with advanced analytics, we see an attempt and a tendency, which is often successful, to industrialize both the data engineering and the modeling pipelines so that they can be automatically refreshed with new data and achieve production of insights at scale. And again, that's a journey that's ongoing, and that we're at the very beginning of that journey in the industry. So with that in mind, I wanted to go to the next page, which is taking a slightly different perspective on largely the same question. It's important to recognize that real-world data have certain shortcomings that aren't present in, say, RCTs, but they also have benefits over data sets that are available in RCTs. And increasingly, we see that with advanced analytics and sophisticated statistical methodology, we can overcome or mitigate some of these risks. That's a very exciting development because real-world data capture an aspect of patient journeys and certain patient populations that are very hard to observe otherwise. So it's a very important objective for patient outcomes. So some of these risks include, for example, treatment assignment or other selection biases. The decision to treat a patient with a certain treatment is not randomized in the real world, so therefore that has to be accounted for. And there are rapid advances, as I mentioned already before, in causal inference with machine learning methods, with advanced analytics, to correct for that bias, or at least diagnose it when it's there and make it transparent. At the same time, we see an increased pragmatism in clinical trials. So in a sense, there are situations where prospective observational trials are approximating real-world data, and we can learn from either setting and sort of borrow strength across the two. Data engineering has traditionally been a barrier to the adoption of real-world evidence generation techniques, but increasingly the big data toolbox has been standardized, even commoditized, one would say. It's scale, it's easy to adopt now in a large enterprise, And increasingly, data vendors are also conforming to standards when it comes to data models and so on. And therefore, there's a set of best practices that are arising in the space, which is making data engineering easier. At the same time, the revolution of deep learning and end-to-end deep learning, this idea of rather than having to generate each feature that describes a patient one by one, relying on a deep learning model to discover it by itself, which is often referred to as representation learning, that's also picking up speed in this space. And that's particularly helpful with semi-structured or unstructured data. A couple of other points I wanted to make include the lack of availability of appropriate endpoints. The endpoint that you can design to observe in a clinical trial might not be exactly available in a real-world setting. So instead, we can rely on proxies using combination of other information, or increasingly digital health markers that are only available in real-world settings and now are being validated, of course, through more formal setups. And these are gradually producing high-quality sensors that can give us a view of a patient journey and patient outcomes over very long-term horizons, which is fairly unique and important. When it comes to data quality, increasingly we have both tools and best practices that arise specifically for real-world data to ensure that there's high data quality and that any issues are automatically flagged. And automation is very important when it comes to quality in general. It's important to have a pipeline that is robust to data quality issues, and these are not discovered post hoc after the fact, but in fact flagged automatically by the pipeline. Similarly, for heterogeneity of cohorts, it's often the case that real-world data has in principle a very diverse population of patients, but in order to identify it, that can require fairly advanced engineering. Thankfully, that's coming into place. And modern advanced analytics techniques, especially non-parametric techniques that are very flexible, are able to capture more heterogeneity than classical methods under the right conditions. And finally, a smaller point, increasingly regulatory agencies are also leading the way, providing very clear guidance on the use of real-world evidence, and we're generating a big sort of growing literature is being generated on the use of, for example, synthetic control arms that we can learn from also in real-world evidence studies that do not involve necessarily a regulatory component. So with that, I'm going to pass back on to Alex to take us through the next part of the presentation.
Thanks, Chris. And what we see is that this increase in data breadth and richness, the analytical approaches, the change in how the industry is thinking about it, is actually opening up the aperture in terms of where in the value chain real-world evidence can create value. And what we see is that although classically real-world data would have been used for natural history studies, feasibility, safety monitoring, that kind of thing, we see that in research and development, there is significant utility and value creation from real-world evidence in terms of using that data to provide deeper understanding on biological pathways themselves in terms of understanding disease progression, drivers of response, prioritization of indications, leveraging not just real-world data, but also a broad range of images, omics, clinical trial data, to really get as close as possible to linking biology to outcomes. And that also comes with a view of getting a much more granular picture of unmet need and understanding patient unmet need in the real world. We also see that being applied a lot to optimizing clinical trial design, leveraging the different data sets that I mentioned to get a more precise view on inclusion and exclusion criteria, endpoint selection, those kind of things. And also automatic monitoring of real-world outcomes just to inform ongoing R&D programs. There's, of course, applicability in market access in terms of demonstration of economic value, but also understanding of disease burden, particularly understanding patients who are perhaps particularly high burden disease before a product is launched. Medical, of course, is an area where real-world evidence has been used for many years in pharmacovigilance, and that continues to be the case. We see a lot of that happening at scale with benefit risk analysis happening in a much more at scale automated way. We see a lot of applicability for evidence of head-to-head differentiation, identifying subpopulations who benefit from specific therapies, and of course, improving the effectiveness and precision with which medical affairs act with a better understanding of the real-world treatment and unmet need. And then from a commercialization perspective, of course, the real-world data can inform strategic and tactical decisions based on understanding of patients that use the therapy, drivers of switch, adherence, discontinuation, and in some cases, even informing decisions at point of care with clinical decision support systems based on identifying patients who might be undiagnosed, patients who might be at high risk, for example. And with that, what we wanted to do is show quickly one example of a use case for looking at head-to-head comparisons. And what you see here is a sanitized output from this use case, just as an illustration. And the bubble chart is the aggregation of data from a patient-level predictive model. I won't go into the details, but it's effectively a model that we ran on a large electronic medical record and claims linked data set. And that model uses some of the methods that Chris described to effectively look at hundreds of thousands of patients, each of these patients having 5 or so years of longitudinal data and hundreds of different disease characteristics, some of which you see on the right-hand side, spreading from demographics, comorbidities, co-prescriptions, disease severity, biomarkers. And the models are able to look at these patients and predict what their outcomes would be on different therapies, controlling for these confounders. And so understanding what would happen to these patients if they switch from therapy B to therapy A, with all else remaining constant. The bubble chart is the aggregation of that model into a subpopulation level view. And so what we have here is on the X and Y axis, we're looking at the difference of a subpopulation between the average patients. We have here in the middle the all patients bubble. And you can see the size of the other bubbles represents the size of the subpopulation. So if we pick an example, this is patients with a BMI between 32 and 34. The position on the X-axis tells us that any subpopulation to the right of the X-axis has a lower event rate. They have improved clinical outcomes because the therapy is ameliorating has reduced in frequency. So we see that this subpopulation is having better outcomes on therapy A than the average patient on therapy A. We also see as on the Y-axis the differential response between therapy A and therapy B. And again, subpopulations above the 0 line have improved outcomes on therapy A compared to therapy B as predicted by the model. And what we're able to do then is double click on a given subpopulation. So this is the model predicting that patients with BMI between 31.8 and 34 will have an 18% improvement in their clinical outcomes if they were to switch from therapy B to therapy A. And because it's linked claims and electronic medical record data, we can also look at the cost of those events and therefore the cost saving to the system by that switch. You can imagine that this has broad applicability in a number of situations. This has been used for hypothesis generation for subsequent publication, for informing discussions with healthcare stakeholders, regulators, and payers, for informing R&D discussions based on a more granular understanding of response and drivers of response, and informing franchise strategy and tactics. And increasingly what we see, to Chris's point about industrialization, is moving away from this view, which is therapy A versus therapy B on one endpoint, to a more therapeutic area, disease area wide perspective. So you can imagine that these models could be constructed at a much greater scale, looking at not just therapy A compared to therapy B, but looking at A compared to C, A compared to no therapy at all, B compared to C, and looking at a number of endpoints. So not just acute endpoints, but also healthcare resource utilization, more disease progression, and kind of survival endpoints. And you can imagine that that breadth of insight generated at that pace is obviously opens up a whole world of possibilities in terms of how these insights can be used. And this is exactly what we see is leveraging the underlying analytical approaches that allow for industrialized at-scale evidence generation to create a new enterprise-wide approach to doing this, whereby you can see in the middle of the screen, all of the relevant data sets are pulled into one place, the clinical trial, the claims, the omics, the literature, and analytical models are constructed on top in a very scalable, industrialized, reusable way. So for questions that are commonly asked, for example, comparison versus another molecule, understanding of drivers of switch, understanding of disease progression drivers, those can be built in a way that is very flexible, reusable, and scalable to different therapeutic areas and assets. This center can then obviously answer questions that are part of the integrated evidence generation plan. It can help to close those gaps. It can also inform the formation of these plans with more granular insight of what's happening in the real world to better understand how the strategy should be put together. And then on the right-hand side, you can see that obviously these insights are then disseminated to external stakeholders in terms of patients, healthcare professionals, regulators, payers, and also internal stakeholders, like I mentioned, in terms of informing R&D, in terms of informing strategy, and of course, medical evidence generation. So this is a very appealing vision, but what does it take for a life sciences company to get here? There are broadly 8 dimensions that are necessary. And starting from the top, it's critical to have a strategy that is very specific, linked to the value that you aspire to create in various therapeutic areas and areas of the value chain, time-bound, and critically it has top-down sponsorship. You know, we see leading companies don't just have a vision that is about aspiring to have a leadership position, but doing so to create a specific kind of value in a specific area. Then creating that value requires bringing together cross-functional teams to deliver on these critical use cases at pace, and not just to deliver the analytics, but then to operationalize it, to disseminate it, not just through rapid publications, but also through digital mechanisms of dissemination, and tracking the impact from this work is also critical and difficult. The establishing an organization that can have true integrated evidence generation across the value chain, getting the use of real-world evidence in early enough into the discussion and not having it as an afterthought, and integrating the needs across different geographies is extremely difficult. Chris will talk more about the capabilities, the breadth of different skill sets, and the culture that's required in terms of confidence and a deliberate perspective on when to use different methodologies. And of course, this can't be done in a kind of vacuum. This requires partnerships with the outside world, with analytics players, with healthcare stakeholders, with data companies, and it requires building platforms internally that allow for this evidence generation at scale in terms of lab environments to develop models and factory environments to industrialize them. And what we see is that although some companies have strong positions on these dimensions, there are no companies who have a leadership position across the board. And most companies have a very specific strategic posture on where they want to have leadership. And getting that leadership can take multiple years. And those leadership positions are fragile. It's not the case that once leadership is achieved, people can rest on their laurels. It's a continuous innovation cycle to remain at the leading forefront of the industry. Given how important capabilities and culture are, particularly to the application of advanced analytics in real-world evidence, we wanted to double-click on that, which Chris can do now.
Thank you. What we see on the page is 3 main categories of skill set that is required to successfully deliver real-world evidence transformations, and 2 of them won't be surprising to anyone. So obviously, one needs a team of highly trained data scientists and data engineers with specific skill set in big data analysis and other tools that are required for real-world data. Additionally, of course, it's critical to have clinical input. That is sometimes underestimated by the data science teams, and it's important to have clinical input throughout the model lifecycle. So understanding how to define the cohort, how to choose the right target variable, often a proxy or a surrogate endpoint will have to be used. That's a very sensitive and important clinical decision. So having the oversight of a domain expert, ideally at all times, is the best way to achieve a safe outcome. At the same time, though, there's a 3rd type of capability that is critical for success, which we refer to as a translator on this page. Now, the translator is effectively the person who can translate business needs into advanced analytics and make the right priority calls when it comes to deciding the benefits, upsides, downsides of specific questions and respective approaches. So a translator is not a data scientist or a data engineer. They would have very specific experience working with analytics, especially at least in one specific domain. And they would be very experienced in managing projects, understanding complexity, risk management, and so on. But they're a very critical role in gelling together that team of diverse expertise. And it's also an incredibly rewarding role. So the translators that we've seen are most effective are themselves extremely passionate about the adoption of data science in the life sciences, and they have a vision as to how that needs to be done. And therefore, they're critical in helping translate that ambition from the data science to the clinical teams and vice versa. So acting as a bridge between those 2 communities. The dedication of that particular role is quite important as well. We see that organizations that have dedicated translators that commit close to full time on projects that they're actively managing, or at least in that capacity, if they're managing multiple projects, is amenable to success in this space. And the way in which these groups of experts work is often in the same room or in the same call, but primarily also iteratively. So the agile process, which has proven itself beyond doubt in the software engineering world, is also a best practice here through agile sprints, where these give the opportunity to take a step back, understand the progress, revise any decisions that have led down blind paths, and so on. So this approach enables the teams to test basically both the approach and the decisions made very early, and be agile in revising any decisions that need to be revised. And information upstream is, of course, flowing at a regular pace in an agile workstream. It's not like a project is signed off and then nobody hears from them for months, but instead, on a regular basis, every 2-3 weeks, there's a constant flow of information, getting feedback from leadership about the progress of the project. I wanted now to double click for a moment on the data science bucket, if you like, and make a point that is often lost, which is that we are in the life sciences unique in that there's already a culture of data science, a very strong culture of data science present in the life sciences with an extremely successful pedigree. I mean, it's no exaggeration to say that the doubly blind randomized clinical trial is probably the biggest success story, if you like, of statistical methodology. Very early on in the development of the what we call the data science or machine learning or advanced analytics community, it was identified that there's these two different cultures who here we refer to as the biostatisticians and the AA/ML practitioners, and they have different objectives by default. Biostatistician by default is focused on explanation, explanatory modeling, causal modeling where possible. So when they're looking at a real-world data set, their perspective is, can I recreate as much as possible the conditions that would hold in an RCT so that I can make sure that the results are valid? At the same time, the data scientist or ML practitioner would instead be focused on prediction. How can I define a future data set or hold out some data and test the accuracy of my methods in a data-driven way rather than try to constrain them a priori to a specific approach? And these two perspectives are both valid, and we've now seen the tremendous success that the predictive mindset also has to offer in the form of deep learning successes and successes in machine learning across multiple industries. Therefore, in order to achieve the biggest impact, it is important to have a very clear way for biostatisticians to work hand in hand with data scientists and ML practitioners. One framework to have in mind is that biostatisticians are in fact responsible for the veracity of individual findings, whereas data scientists and ML practitioners are best placed to hold the bar for predictive accuracy and out-of-sample generalization. And these two are actually two different risk mindsets. Both communities have their own risk management processes. Data scientists will focus on avoiding overfitting. Biostatisticians will focus on the appropriateness of the conditions and any selection mechanisms. And in combination, they form a formidable team to achieve insight generation from data as complex as real-world data. So to conclude, in order to generate maximum impact here, there needs to be a use case by use case consideration of how to mix these two skill sets together, understand the remits, and make sure that the priority is placed on whichever objective is appropriate for the use case at hand. Is it primarily prediction? Is it primarily explanation? Is it a mix of both? It has to be a use case by use case consideration. So this is, I guess, our closing remark, and it's, I think, appropriate to end on a point of culture, because in the end, what we see is that leadership generates culture, and then culture is the momentum that persists in the longer term. So with that, I wanted to thank you all for having us again. And Alex, I don't know if you also want to say a word of goodbye.
Yeah, I wanted to echo Chris's thanks for having us, and hope that was informative, and looking forward to the questions.
Thank you very much.
Thank you all for having us. Welcome to this session on Giant Health 2021 and real world evidence, the fireside chat. So briefly by introduction, I'm Alex de Veersen. I'm a partner with McKinsey & Company based in London. I lead globally a lot of our work in advanced analytics in life sciences, and I globally co-lead our work in evidence generation and real world evidence analytics. And today my colleague Chris and I are going to talk to Brandon Allgood Chris, maybe you introduce yourself and then we can introduce Brandon.
Sure, thanks, Alex, and it's a pleasure to be here. I'm a senior expert at McKinsey Quantum Black, where I focus on evidence generation and R&D using data science and AI in the life sciences. My background is primarily academic. I was an associate professor at Imperial College in the statistics section, and I'm very interested in the fusion of statistical methods with AI. It is my real pleasure to also introduce Brandon Allgood, the Chief AI Officer at Tallo, and a co-founder and CDO at Numerate previously. He's also the co-founder and chair of the Alliance of AI in Healthcare. Brandon, welcome.
Thank you for having me. Happy to be here.
Excellent. Brandon, maybe we start with one of the broader questions when we think about trends. How do you see the real-world data ecosystem balancing the need for the linked patient-level granular data that's essential to enable some of the analytics use cases we'll speak about, with the importance of the fundamental importance of patient privacy?
Yeah, so it's a good question. I think right now the ecosystem, as it should be, is really leaning more towards privacy and making sure that patients' data are being protected, that patients' privacy are being protected. This is through various mechanisms such as IRBs and isolating data, really making sure that data is being aggregated properly and that there's no re-identification, even by accident re-identification of patients. And I think this is the right way to go. I do think, however, we need to be leaning towards, while we need to continue that good work around privacy, FAIR principles in terms of fair data is something that has not quite fully made its penetration into real world data, and I think it needs to. And that's one of the things that I would say is kind of holding us back and really kind of preventing us from moving forward while protecting those that patient privacy. Another kind of issue that exists in particular in the United States is the fragmentation. I can tell you right now, as someone that obviously pays a lot of close attention to that and someone with a chronic disease, my data is at least in 6, if not probably more, different systems, and I don't think any single healthcare provider or organization would be able to see the entirety of my disease. I aggregate it and give it to all of them, but if I didn't do that personally, they would not have that, and it would be really hard to understand the progression of my disease.
So that's really interesting to note, and in particular with regards to FAIR principles, it's interesting how a concept that took hold in the research ecosystem is now actually proving useful also in the healthcare system at large, which is an operational system. It's often collecting data primarily for administrative reasons or operational reasons, and therefore perhaps wasn't designed in its entirety with FAIR principles in mind. What's your take with regards to the degree to which FAIR principles are already in place and actionable in the research data ecosystem as opposed to real world data? Is that gap still present, or are we observing the same level of fragmentation also in the research data ecosystem?
So in research data, we are doing better, obviously. So in research data, you often involve data engineers at an earlier stage, planning for the capture, planning for the storage, planning for the explorability. So I think while we're not there completely today yet, but on the research side, there's certainly more thought that goes into it early on, given the individuals that tend to be involved in those efforts.
That's right.
And that's obviously one piece of the puzzle, but there are many different healthcare stakeholders involved in the kind of real-world evidence ecosystem, and we talk a lot about how their perceptions with regards to real-world evidence, and particularly with novel analytical methods for real-world evidence, are changing. From your position in the industry, how quickly do you see that moving, and what are the potential challenges to that moving in that direction?
Yeah, so I think the speed in which that moves actually depends on us. right? We need to. It's incumbent upon those of us that are consuming those data and producing insights to show the benefit while simultaneously protecting the privacy. I think it's a building of trust, and showing these healthcare providers and other stakeholders that there's a lot of value. And so, there's certainly a fear of AI, because AI is again is seen as something that's a black box, that's a mystery that could potentially do harm, and people worry about loss of privacy. But I think we need to show them what's possible and show them that we can protect it. I think also what they need to see to build trust is diversity. Diversity among data scientists, among those people working with the data, diversity in terms of the types of data we're collecting, not just in the kind of major centers like Cambridge and San Francisco, in these other places where, at least within the United States, those are the predominant sources of data that we actually go in, partner with organizations, with communities that are underrepresented, and make sure that those data get in. So I think there's a number of different things that we need to be doing as a collective ecosystem to further bolster that trust.
I think that's right. And it's interesting that it's coinciding with a more general movement in AI and data science in general, recognizing the need to sort of self-regulate almost as a community and understand what it means to produce reliable, trustworthy, and ethical AI. And some of the best practices that are arising out of that, like, for example, detecting bias, measuring diversity, understanding the fairness profile, but also taking challenges such as selection mechanisms more seriously and in a more head-on fashion. I think this risk mindset in general that the AI community is adopting is actually going to be very helpful in this particular domain. And it seems to me that AI in the life sciences might actually end up being perhaps a slow adopter at first, but eventually a thought leader in how much care we need to take, additional care, to ensure that AI methods prove the benefit, but also protect against possible risk of harm in the ways you just mentioned, Brandon. It's an exciting space, and with real-world data, the selection mechanisms that are in place are increasingly becoming known, and we're studying them and understanding them, and therefore we're one step closer to mitigate from that.
Absolutely. Yeah, and I think the fact that I agree with you, we will, as an industry, be the leaders because of just the base that base of privacy, of concern for privacy, making sure that we are taking the best care of patients, where in places like the internet, social media, that's not where there's not that base. They have to kind of retrofit in many ways that concern and that thought process.
With that, I think will be a very high bar on the industry to know when to deploy which methods, when they're appropriate, when they're suitable, when they can actually kind of add value over other methods. To that end, I mean, we speak a lot about the potential for more advanced approaches in real-world evidence to bring value in R&D, in medical, and safety, whatever it might be. Where do you see the most potential impact from deploying these new methods? Again, notwithstanding everything we discussed, assuming it can be done in kind of an appropriate way.
Yeah, I think the primary place, the place I've been most excited about for quite a while, is in pharmacovigilance, is in post-market analytics, making sure that the drug products and the therapies that we're putting out there are truly safe and efficacious. And the fact that now with the movement of IoT, where everyone's wearing a device of some sort, so we're collecting more and more data on individuals, which means more and more data has to be streamed back to the companies that own these, or that are administrating and own these products. And so they need to sift through more and more of that data. And I think at this point, machine learning analytics on that real world data is important, because we are just not, human analytics is not going to scale exponentially while the data that we're generating is scaling exponentially. So I think pharmacovigilance is one of those places where it's not a luxury; it's absolutely required that we deploy machine learning in order to keep up with and make sure that we are protecting, like I said, the efficacy, making sure we're ensuring efficacy and protecting the safety of individuals. I think following pharmacovigilance, I think we're going to see a lot more work in the R&D space, like the work that Chris is doing in applying analytics to real world data, bringing together various data sets, bringing together not just real world data, but combining real world data with data sets that I would say not everyone's really thinking about bringing together: biological data sets, chemistry data sets, combining them together using data fusion techniques that we're still working on and innovating around to build a bigger picture, a broader picture of not just patients and disease journeys, but really understanding fundamental biology. I think you're also the other area you're going to see this in is in the medical side, as we start to see more companies doing telemedicine. I think with one of the interesting things about what COVID did for us and forcing us all to sit at home for that last year and a half is we've seen a very large investment in telemedicine, in handing doctors more tools, providing them more analytics so that they don't necessarily have to rely on that face-to-face meeting, that they can actually collect data using devices we already have in our homes, having telemedicine integration. I think there's a lot of things that we're already seeing coming out of the medical side, and we'll see more of that in the future. We're going to be going to the doctor, I think, less, but collecting more data for them to look at and analyze.
And Brandon, probably if I take away anything from your answer, it's not an or, it's an and. Right, it's not that we're going to see this being deployed in one part of the pharma value chain. It's going to probably be essential in many areas. To your point,
right? Yeah, and I think where it's likely going to be slower, for good reason, is going to be in the clinical side, where we have regulations and we need to make sure that we're protecting patients, making sure that the models we're developing are fair, unbiased, and so I think they're just due to the nature of the clinical side, it's going to be a bit slower. But I think it's actually that's where I get the most excited, and that's where my hope is that we start making more. That we build partnerships with regulators, and that we really move the system forward, because I think that's where the biggest potential benefit comes from. And obviously, if you get something approved and you work with regulators in the clinic, that then rolls into the market as well and becomes a medical tool.
I think that's sort of a very interesting question I wanted to pause on for a moment. When we talk about data fusion across different types of data, but at the same time wondering about how different use cases are enabled by real world evidence, the fusion of real world data with clinical trials in particular seems a very exciting space. And there can be novel bridges to that, like you mentioned, for example, digital wearables becoming endpoints perhaps in the future that are then shared reliably across both sources of evidence. But perhaps there are other ways in which you see those two sources being used together.
Yeah, so again, another thing I'm excited about is kind of the advent of or the broader use of pragmatic clinical trials. So being able to go into a healthcare system that is more integrated, and actually selecting patients out of that healthcare system to enroll in a clinical trial, run the clinical trial, and then continue to follow them in the healthcare system post-clinical trial. I think this idea of being able to really understand and capture the patient journey up to the clinical trial and post-clinical trial is going to give us a lot of deeper insights into the disease progression, into the diagnostics, into the types of interventions that we have. So very excited about that. I also, again, clinical trials, most clinical trials today, you collect only the data you need, right? And again, the clinical trials are run in a way very similar to what Alex was talking about, in that they're collecting data not necessarily for insights and analytics, but to answer a very particular question, right? And I think if we go into if we start to think about clinical trials in a different way, as not just collecting data to answer that one question, the one question that the clinical trial is attempting to answer, but to see it as an opportunity to monitor disease, to monitor patients, to contribute a broader understanding of that disease through the use of that data. I think some companies are starting to think about that. We are definitely thinking about that and moving in that direction at Ballo. And so I think that's another thing, that will help us kind of bridge the RCT to the RWE bridge, because then you start to actually collect more data that you can connect.
That's exactly right. I think that thinking about the methodologies themselves now for a moment, like we've talked a lot about how bringing the best of AI and ML, machine learning, and statistical methodology, of course, to bear on this problem can unlock a lot of value. But what do you see, if anything, in specific as the next frontier of innovation in the analytical approaches that are used for real-world evidence, if we're going to get technical for a moment? And how do you think companies should prepare for that?
Yeah, this is a big question. I think innovation that's happening right now in causal inference, the kind of work again that you work on, Chris, are the places where I'm very excited about bringing in insights, being able to make the kinds of models that we build more explainable, more interpretable, kind of merging those. But again, like we talked about, the data fusion ideas, being able to develop methods to bring in all sorts of different types of data, combine data from different systems, and even combine data, not necessarily about being able to use tokenization and combine data on an individual patient level, but to be able to identify the same sub-patient populations in two different systems, and then being able to fuse those, which that also in an interesting way avoids some of the privacy concerns, because you definitely know that there are two different sets of individuals, but you've identified them well enough that you know that you have that distribution of disease state and other variables that you can use to combine them. And I think in terms of companies getting ready for this, we as an industry are no different in this way than others, in that the number of people in the world with the skill sets to both understand the chemistry, the biology, the epidemiology, the various aspects of an already pretty complex industry, and then combine that with an understanding of statistics and machine learning. I think it's just right now it's a matter of being able to train those individuals, being able to find those individuals. So I think one of the things that companies can do is internally begin to develop cross training programs. At Ballo, we I would say talk almost on a daily basis about how we start to develop bilingual leaders. Bilingual being 1 foot in the medical side and the biology side, and 1 foot in in the machine learning side, and you can see them. We have some that are titrating from the machine learning side over to the medical side, and some that are kind of titrating over from the medical side into the machine learning side. So I think we need to, at a university level, be training more individuals in kind of skill sets like statistics and machine learning. And there are some universities that are, foregoing calculus, and instead of calculus, teaching more linear algebra and more machine learning and statistics, because in many cases those are the skill sets that people are going to use. But again, we can't wait for the educational system to catch up. We as an industry need to be focusing internally on training programs to make sure that we have those bilingual leaders and that we're kind of preparing ourselves for the future.
As a brief follow-up point, this reminds me in part of the prophetic paper by Leo Brayman in 2001 on the two cultures, where he's at the onset of the machine learning wave at that time, he made the point that statisticians are often sort of culturally in favor of models that are explanatory, truly explanatory, in that they have a specific theory about the mechanism that's generating the data, and they want to confirm or disprove that theory. Whereas the machine learning sort of wave and ecosystem is more focused about predictive accuracy out of sample, which is also a way to validate an algorithm, but in a different way. And this bilingual, maybe there's a third dimension to consider, right? There's the clinical language, and there's the statistical language, and the machine learning communities. And I wonder how, as a leader of an organization that is combining all these three groups, how do you approach that on a day-to-day basis, that fusion of the cultures?
Yeah, so again, I think we often describe Valo as the first end-to-end, the first digitally native end-to-end pharmaceutical company. And part of that is not just the fact that we rely a lot on machine learning and data, but and don't get me wrong, just building the technical capabilities to go after these problems is really difficult, but it's 50% of the effort. The other 50% is making sure that these cultures, the problem we just talked about, that these cultures are working properly together, making sure that incentives are aligned from across the organization, making sure that the data scientists and the clinicians, or the data scientists and the biologists and chemists are working together. And so there's a lot of effort that we've done in putting together teams, making sure that those teams understand that one is not in service to the other. One sub-discipline's not in service to the other, that they're all accountable for the success and failure of certain efforts. And so I think it's an ongoing effort. I can't say that we've totally solved it, but we are actively experimenting and often failing at this. And I will openly admit we're failing at it sometimes, but actively thinking about how we design teams, how we set up incentive structures, how we make sure that we're getting the best out of all of the worlds.
Yep, that makes a lot of sense. And I guess as a final question, one of the classic failure modes that we see the industry falling into is doing something really innovative and groundbreaking once, and not being able to scale that to other diseases, other products, other scientific questions, whatever it might be. How do you think we break out of that cycle? How do you think we move from one use case to analytics at scale? And obviously there's tons of discussions about MLOps and all things like that. What do you see as the biggest kind of enablers and unlocks there?
Yeah, well, so with our industry, right, we have a really long tail of what I would call long tail of data, right? In one narrow slice of a therapeutic area, you have certain data modalities that are critical to diagnosis, to treatment. But if you even within cardiovascular disease, for example, you move slightly in terms of indication, and all of a sudden those data modalities change. the timing of when you need those data from, in terms of disease progression changes. And so really kind of there's this what I call long tail of data sets that we need depending on the disease. So I think, in many cases, I think we need to be taking clues from from more high tech, more kind of here in Silicon Valley, thinking about platforms, thinking about providing platforms, providing not only platforms, building and providing those platforms not only internally within our own companies, but more broadly, right? Starting to share those capabilities, share those data, and really kind of build up a set of tools that even though we have that long tail of different disease modalities, different data needs, as we start to kind of build up the backbone, the ML ops, the platform pieces, the data fusion techniques, we will begin to be able to generalize, and we'll see generalization, right? This is one of the things that's really tough, but this is not an unknown problem in technology, that you don't know exactly how this is going to generalize. So you need to start building up the basics, start with the data layer, start with the ops layer, start with the ML layer, start to build up, use it, continually use it in various places, see, oh well, this pattern is emerging from what we're doing here, let's build that next piece, let's build that next API, and then start to expose that. So I think we need to take we as an industry need to take much more of a platform view to this. While, again, we're used to thinking patients and thinking again, very much towards individual indications, individual things, and we end up with these ad hoc analyses, which are great for that small group of patients. But it doesn't. But other than teaching the data scientists, go, oh yeah, we did this one thing like 5 years ago, and I think I'm kind of seeing that pattern again in the thing I'm looking at today. I'm going to redo that, right? I've seen that. I've seen that both in real world data. I've seen it in chemistry. I've seen it in biology. I love those moments where I'm watching these individual practitioners, be it clinicians, be it epidemiologists or medicinal chemists, even, you start to see that they've got this kind of, they've built this pattern, they've built this kind of recognition engine within their own brains, and they can see it. So that there's an ability to build generalized capabilities, because you can see it in individuals that are practitioners of it, right? So as we start to do that, we needed to kind of distill out of them, what are those patterns? What can we platformize, if you'll let me use a made-up word, and put behind APIs that then can be used more broadly by not only data scientists, but by the primary scientists themselves.
That's fascinating insight, Brandon. Thank you very much for your time. I think we're just about on time, and I guess by way of wrapping us up, I wanted to take a step back and think about how important to the public and to patients the promise of AI for the life sciences is. Yeah, I mean, it's something that people have been waiting on for a while, and it feels like we are at a pivotal moment in the history of that evolution. I think increasingly the AI community has matured. It's developing best practices. It's using replicable and reproducible technology. The capture of data, the digitization, in part driven by other factors like, for example, telemedicine, as you say, is itself maturing and becoming more standardized. And I think we are at a crossroads, and it's sort of on us, as you said earlier, right, to take that challenge head on. So it was a real pleasure talking to you today, and I think that we can now open up for some Q&A. Thank you, Alex, as well.
Thanks, Brandon. Thanks a lot.
Okay, folks. So that was a pre-recorded session, so we're not going to do Q&A, but we're going to move on to the next and final session today. If you bear with us for just a couple of minutes, we're going to just set up the stage for a panel discussion. So please hang on. It should be a great talk around age tech and age-related technologies in wearables specifically. So do hang around a couple of minutes, maybe less, and we'll be back with you. Okay, so welcome back to Giant Health for the final session of today. Great to have you all here. Nice, a lot of people in the room still. I know things are winding down after 2 days back in person. It's been fantastic to meet lots of new people, and I'm sure you've all had some great connections and interactions. We're going to have a discussion now around a topic that's close to my heart in terms of wearable technology, but we have some experts here who are going to talk specifically around their experience and what they're doing out there in the real world. And the topic of today's panel discussion is supporting better aging through wearable technology. So I'm going to leave the speakers to introduce themselves, and then we're going to dive in. One thing I will ask in a moment is just to get a sense of who's in the room, and then we can kind of tailor what our answers are based upon that. But we'll do the introductions first, and then we'll come back to that. So let's start at the end. Catherine.
So, hello, I'm Catherine Church. I'm the Chief Digital Officer for Surrey Heartland's Integrated Care System. And for those of you who are not familiar with how the NHS operates, Integrated Care Systems are a new statutory body within the NHS, which brings together health and social care as an integrated way of managing and delivering health and social care in the UK. As of April the 1st, there will be 42 integrated care systems, and I'm the Chief Digital Officer for one of them. So Surrey is the patch that I operate across. So we're quite a large geographical patch, 1.1 million people, rural, quite rural, relatively wealthy, but with real pockets of deprivation. And we also have a quite significantly higher proportion of elderly people, so older adults in our patch. And that is both older adults and carers. So more people with carers and older carers. So this is a really important topic to us.
Hi everyone, my name's Louise Rogerson. So I'm a physiotherapist specialising in neurological conditions and older people. I'm the co-founder of House, and House is a home monitoring system and designed to help healthy ageing and keep people at home for longer. But I have also worked in the NHS for quite a long time and worked as a commissioner. So I've got quite a breadth of experience in this space.
Hello. Yep. So hello everyone, my name is Zeke. I'm the founder of a health tech startup called Milbotics, and we are creating smart socks to address behavioral issues with dementia specifically, but also with wider applications in telehealth. I think my sort of journey into this area began with my great grandmother, her having dementia and going through the process of developing behavioral symptoms. That really kind of kickstarted my journey into this area, led to a PhD, relevant PhD, and now I'm really trying to commercialize that research, hopefully with real impact, I'd say.
Fantastic. The microphone's magically working again here, so I've got this one. So first of all, I wanted to just see who's in the room. So we've got, I reckon, 25 or 30 people here. I've got 6 categories. I'd love a hand for anyone who's in any of these categories, who considers themselves predominantly in one of these categories. So I'll run through them first, and then I'll go back through, and if you could put your hand up on cue, that would be fantastic. So investors, entrepreneurs, healthcare professionals, first 3. Academics, corporate or SMEs, and other. And I'll come back to the other afterwards. So I'll just run through again. If I could get a show of hands, I expect a hand from everyone. I shall be coming back around if you don't give me one. So please tell me who you are. Investors, first of all. Who's investment people? Fantastic. So 1, 2, 3, 4 investors. Entrepreneurs. Great. 4 or 5 entrepreneurs. Healthcare professionals. 1, 2, 3. I think, Louise, you're an entrepreneur predominantly, aren't you? No? Okay. Academics. Got an academic here. Corporates, SME. Couple of corporate SMEs. There's a lot of people going to be in other then. I want to show of hands from everyone who didn't put their hand up before. Right. So I'm going to pick on you over in the corner. What do you do? Where are you from? Okay, fantastic. Anyone else who had their hand up? Yep. Clinical director. Okay. Next. Yep. You have to speak up a fraction. Regional government in Belgium, fantastic. Well, I didn't have that on my list, so fair play. Anyway, anyone else? Were you? You're done, were you? Anyone else want to put their hand up and tell me where they're from or what they're up to? No. Okay, let's leave it at that. That's great. So a pretty big, great mix, in fact. A good balance between who's here, and we know a little bit more now about who we're talking to and what we're going to ask. So we've decided on a sort of framing for this discussion. So we're going to start with just putting that out there so that you know kind of where we're trying to get to, and we can ebb and flow and move forward. We'd love some questions. So if people have questions, stick your hand up, ask those questions on the fly at the end, whatever. We're not going to sort of have any real formal process here. It's going to be a kind of Q&A and a discussion. I'll just keep things moving, hopefully. So the question that we posed is, we want to explore the state of play, opportunities and blockers in the development of products and services to support better aging through wearable technology. So the key words there, I guess, being opportunities and blockers. So where are the challenges that we're facing? Where are the actual opportunities that exist? And those working in the NHS will really understand how to deploy those things and what works and what doesn't. So we'll kind of converge on those themes, and hopefully at the end we'll have a good understanding of that question. We'll see. I'm going to go in reverse order, I think, and ask you, Zeke, first of all, to kind of try and give us a starter for 10 for that question. Opportunities and blockers in terms of healthy aging.
Okay, well, I think it's been widely recognized that technology has a role to play in promoting healthy aging and promoting really better outcomes for people as they age, as well as around disabilities and general health. I think that the funding is starting to fall into place. So certainly with Innovate UK, so I've been applying for a lot of grants to try and get my company started. There've been quite a few opportunities over the past sort of 6 months. So I've been able to apply, have not quite heard back whether I've been successful yet. So that's another question. Is there sufficient funding given the level of demand for that funding? Yeah, I mean, I think, like I said, it's been recognized. It's a case of now, can the support that's needed be made available to the people that are trying to deliver that change?
Okay, so I have several hats, but I think for me, the question about healthy aging is there's a myth that, so I have a bit of a personal thing about pictures of older people doing like a skydiving and stuff and going up to space and all of those kind of things. The reality of it is aging is actually quite hard work. You are unfortunately sitting here declining, and you need to really work on that. And the people who are looking after the older people who are declining themselves. So if anyone's been in the situation with mum and dad at home or grandparents, because I'm like quite old now, but you can see that they're that dynamic between them and they're aging together. And what you see is this really amazing ecosystem between two people propping each other up. And we were just saying earlier, one of those breaks and you are in trouble. And for me, healthy aging is about maximizing what we can do. Don't accept the deterioration. You can work as hard as you can, but also don't be afraid of stuff that will help you. So I like to focus on your positive aging journey. It's okay that I've got a few more wrinkles. It's actually fine. We have to just go with it. So I would say, for me, technology needs to be more embedded in daily life, but more constructive and make the data very, very relevant about stuff we can do something about. Telling me the depth of the wrinkles on my face is not going to make my life better. But telling me a muscle that is weak, that needs strengthening, or balance that is starting to fail, that I can do something about, is really exciting. And that, for me, is where the technology needs to be. Think elite athletes monitoring their performance all the time to improve it. That's what we need to do. And older people getting that technology and stop seeing it as something to monitor their failings, but to monitor their progress.
Brilliant, thank you. So thinking about that, there's huge opportunities were made really obvious to the NHS as part of COVID. So February 2020, we just moved overnight to not wanting or it not being appropriate to send clinicians into people's homes. And we were doing everything that we possibly could to avoid people from coming into hospital who didn't need to come into hospital, of course, because of all the infection risks and the fact that there were many other people in hospital with COVID. So that whole building an ecosystem around people that enabled us to ensure that they were as well as they could be in their own homes is extraordinarily important. Opening up portals into people's homes so that practitioners, clinicians, physios could actually come into the home and carry out things like virtual consultations. So be that in somebody's home or in a care home was really, really important, and something that we deployed at quite some scale. And then I think you're spot on, Louise, is ensuring, especially when people were isolated at home on their own, that their carers were well and safe. So having an ecosystem that enables you to ensure that the carer, the person's carer, is getting appropriate rest, is getting appropriate support, is getting contact, human contact, as well as contact from medics is extraordinarily important. And one of the things we did in Surrey was actually scale some remote monitoring ecosystem, an ecosystem of connected medical devices to do exactly that. So when you can't get people coming into medical establishments, ensure that the medical establishment can reach out into their homes.
There we go. Super. Thank you, Catherine. So let's go back around just linearly again with the next question, which is a general one. So in terms of your experiences and what you're up to, you've just kind of touched on that. Can you just sort of give us a bit more in terms of age-related conditions that you've interacted with, and especially with that sort of pragmatic lens, what are the things that you're finding really have got solutions out there that you've touched, I suppose? It's dead then, right? Okay.
Well, we'll have to swap.
I've got really
There
good
we go. So the things that we're focusing on age-related conditions are frailty. So if we look at actually the conditions that in our patch in Surrey, the things that are affecting the most people and that have the most impact and consequences on the NHS are frailty. Frailty and falls is a huge driver of visits to GPs, of conveyances to A&E, to GPs going out to people's homes and admission. So that's going to be a constant. That's going to be a constant for anybody in the NHS is understanding people's tendency to fall, the impacts of falls, getting services wrapped around people so they're not lying on the floor degenerating before ambulances can get to them. And there's the converse, so there's the whole admission prevention, but then there's also the enabling discharge. And the majority of people who are stuck in hospital are because it's not safe for them to go home, or we haven't put in place the support mechanisms for people to be able to go home. And that's complicated. It's coordinating big packages of human care from maybe a range of different agencies that are pressurized. And that's where really the opportunity for tech is so strong. So we're working on a number of programs around packages of integrated digital and hands-on care that enable people, so that can be prescribed in hospital to enable people to leave earlier. So that's one major area, and the other is dementia, but we've got colleagues who are more expert on that, so I'll pass on to Louise.
So I think if I think back to my physiotherapy days when I qualified, we used to see people with neurological, like stroke. You would see them at home, you would keep seeing them for quite a long time. Parkinson's disease, we keep seeing them over a long period of time. Now, unfortunately, we can't do that. So if anyone has the misfortune of going to see a physiotherapist these days, A, we are brutal. It will hurt. And the second thing is you'll end up with a big wad of paper to go home with. And I think that's a bit of a disappointment for me. I trained for 4 years to not be replaced by a piece of paper. Going to video is not transformational, but physiotherapists think that is transformational. Ooh, video consults. No, what's transformational is actually what we do when we see people is that I'm watching you walk, I'm watching you sit, I'm looking around the room thinking, oh, that's a lopsided shoulder. Imagine if we could have technology that would pop out and say, actually, this is brewing. This is starting to be a problem. And actually then we could put our intervention instead of into monitoring, but actually into delivering an intervention. Really exciting, because this means that you can actually spend your money at the point of need rather than spending a lot of time checking in and assessing. And if you ask patients, and I'm calling them patients deliberately, if you ask patients to contact you when they need to, you can guarantee it will be late, way too late. So technology opportunity for me, it's all about that. And that's what wearables are. It's that continuous monitoring. And our analytics that we've developed is change detection. So the point of change is the point where you need to sit down and say, what has changed now? Because now is probably the time to do something about it. So I think that's for me.
Yeah, so I'm primarily focused on dementia. And I've been talking to a lot of care homes, and something that I've found that they struggle with is really around the training and the fragmentation of the technology landscape. So a lot of care homes are looking at adopting technologies, but they're finding that they've got to install a dozen different apps. Each time they do that, they have to train the staff. They've got very high rates of staff turnover, and they're constantly spinning on a wheel, trying to get the technology working for them. But in the end, they're investing more effort in just getting the technology in place rather than deriving benefits from it. So I think that fragmentation of the landscape is something that really needs to be addressed. And I think probably, Louise, you're working in that area with, bringing everything together. And then another issue that I've come up against is around stigma. So people with dementia tend to be quite private about the condition. They don't really want to publicize the fact that they have dementia. And you find that certainly with wearable technologies, they can be quite stigmatizing. Wristbands, devices that are very, very much on view. It causes that concern that people are going to single them out as being different. So I think that's something we need to work on, and certainly through the work that I'm doing with Smart Socks, really looking at providing something that is non-stigmatizing, very familiar, something that can fit in with people's daily lives, so they don't have to change their behaviors. And that can provide that sort of remote data to clinicians potentially to, improve health outcomes and provide benefits.
Thanks, Zeke. I'm going to ask Catherine to touch on that sort of, I think we jokingly have called it badges of vulnerability and various other things, this kind of pendant around the neck stuff. What's your experience with that sort of technology?
Well, so again, from working across, and it tends to be local authorities that have these telecare or telehealth program, and they're as old-fashioned as the word would indicate. So the pull cords that people have around their necks with the horrible big red button, and they're really nasty grey plastic. Sorry if there's anybody in the room that's a manufacturer of these devices, but they would acknowledge that themselves. And the TSA are doing a huge amount of work to really think about that form function. And the customer experience. So the whole range of things that we see, crash mats, decelerometers, devices on the wrist, things that go around the neck. The main thing that happens, in fact, most of these are associated with the monitoring service. So there's somebody at the end of the phone, or they can bring an ambulance out, and they'll find that half the time the individual has knocked the device off the bedside table because it's really horrible, or they've turned over and it looks as though they've fallen, and that triggers all kinds of false alarms. And then, of course, a lot of people, and they're often given to people with dementia, so you can track and see if somebody is fuging, which is a horrible word, actually. It's a really horrible word. But if somebody has got confused and has wandered into places that may not be quite so safe, then the first thing that anybody does is take it off, as you say, that badge of shame of there's something weird and different and someone's going to come and take me home. So we just, the outcomes are not great. There's some amazing people who work in these environments, and there's some really, really good work done. But think about that versus the usability of a Fitbit. Nobody. It's a badge of pride to have an Apple Watch. And if we could actually create the same kind of form function, or a really cool pair of cashmere socks that people would be proud to wear, then I think we'd be onto a good thing.
Fantastic. So we'll come on to whether there's bill of materials budget for cashmere in your product. Louise, Fitbits were mentioned, and also what I thought was interesting in that is the idea of service, and we talked about this recently, local authorities having budgets cut. Can you talk a bit more around that idea of the service and the and those things? Yeah.
So all the work we've been doing, so we started with home monitoring and an app, and it'll tell you when things are going awry, and it's for the family, blah, 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 blah. Technology, we worked with an organization recently, a health organization. They said, I want technology that never fails and works all the time. So I left. The point is that it doesn't work all the time. None of it does, right? And so what we've been doing, and we've had the opportunity to work with Catherine in Surrey on this, which is providing the service that goes with it. So what we had to do was, and we had to trust that our kit could be self-installed. So I spent a lot of time with hardware, seeing how hard it was to open, batteries that last a long time. And what we've realized is it is the service. So the evaluation of the Surrey service is not that the technology alone will keep people at home, but it's the service that goes with it. I did some work recently. We had a geriatrician going to visit some of our customers to do an interview to see where we were at. And he came back and he went, "Oh, they love you guys." And I'm like, "Of course they do." He said, no, your customer service is amazing. Like, you're amazing. Like, you're so there. And I'm like, I've probably heard from them once a year. But the fact is, when they do want us, we are there. And the Surrey work is that when something goes awry, we are ringing them. So they believe someone's got their back. And I think that's what we have to do, is someone's got your back. I don't know. Is anyone here a carer or aware of a carer? Yeah, right. So sometimes you just need someone to go, "Oh, last night was a bit rough, wasn't it? You all right? You had a cup of tea this morning." And that is what actually makes a difference, because I can't come and care for the person. That's not possible. So one of the things we need to look at is a service where you've got a carer that goes and visits one afternoon a week. How much does that cost? Could a technology go in there in a service that just checks in at the point of need? Could that then be done for the same amount of money? Yeah, it can actually. And also empower families to do it. Families involved in a service. We so often discount families in our planning. So let's bring them in. So I think we've got to, what we are doing now is providing a service that goes with the technology, and you want to get in with companies that do service to help alongside your technology. You know, we've got to work together to do this. And what we're doing is taking all the admin side out, all of that admin, the technology, when they do a reading and it says blood pressure 290, you wouldn't be ringing me if it was 290, would you? So let's just sit down, wait 10 minutes, do it again. And only then, if it really is up, so we had one the other day, 171 over 126, which gave me anxiety sat there, I have to tell you, because a diastolic that high is not great. But the monitoring team were there. They contacted the GP practice. They put him on a new medication, and he started that day. Without his blood pressure at home, that wouldn't have been detected. But it needed some sense to say that is a real, genuine reading. And we did it 3 times and it was real. So those service side of things, very, very important. And you've got to talk to the people that are going to do something about the things you're finding. Don't give me stuff I can do nothing about.
I'm gonna stick with you a minute and just go back to sort of the local authority bit, because we talked about how funding had been cut in many cases. Finding technologies that slot in to deal with that health economics issue, basically. Are there big kind of candidate areas where you can have less of that personal service and that cost, and technologies to drop in easily? Or are you just going to say, no, we need lots of people on the street?
Well, it's interesting, but it's very, very unpopular to say you're bringing people out. That is like the last thing you're ever going to say.
It's reality though, right?
No, it is the reality, but the last thing, well, I'm saying the last thing Boris would say, but let's be honest, he probably would say it, wouldn't he? But what you don't want to stand up and say is, we've got a technology, which means no one needs to see your mum anymore. That is not that.
Yeah. So just to add into that, we're never going to be taking people out because there is so much unmet demand. So it just allows you, it just allows you to the scarce resources that you have to really deploy them at that point of need.
Yeah. So what we are seeing now is that local authorities are starting to switch on to the idea of predictive. So they are looking, they don't want reactive anymore. They've started to realize that telling you too late is costly. What we are seeing is they do want care optimization. So if you've got something that you can put in that will allow them to be more efficient, so like I say, getting rid of check-in visits, then there's definitely opportunity there. Tenders are starting to come out now, so they all seem to be on a bit of the same 5-year cycle, so they'll sort of the next year or two. And what we're seeing is more requests for predictive technology to go in. So whatever guise that's in, there's definitely space there. That is an opportunity. And I think the other side of it is self-funding. Councils, when you go to the council and the council said, we can't help you, you don't qualify, the next thing they do is they give you a list of things that's self-funded. Most councils, it is just a car crash of kit, and you wouldn't have a clue. So you end up going with the incumbent telecare provider quite often. So that is a disruptive space needed. So social prescribing, getting it a little bit before you hit that point might be another place to go to integrate with some of those systems to get yourself on that option list. That's something we're trying to do now.
Fantastic, thanks. At that point, are there any questions that have come up so far in the discussion? Have a think. There's a few themes we've talked about. You know, the pragmatics, I suppose, of what's out there and what can be done. The service, you know, things that are actually happening out there in the NHS. Some of the challenges. Yeah, you're going to heckle like promised.
Really good panel debate, by the way. I just wondered, how do you deal with this dynamic when you are incorporating a new technology like wearable tech? You know, there's going to be some sort of expense at the beginning, but you're working in an environment where you have to save money. How do you deal with that kind of dynamic to make a valuable case? Because that in itself is going to take a bit of investment. How do you deal with that tension?
Well, you smile at investors in the room for a start. And I can do a bit about it just from our side. We did a lot of accelerator programs. We got in with, we made a specific decision to go via the commercial sector. So we went as a consumer proposition, worked with utility companies to prove our worth, then went to the NHS with a thing that was done, that had been through the rounds a wee bit. And the work we did was, we also did supported work with universities. So we supported a PhD, we supported postdoc work to get some of that hard research done, to get the evidence behind it. So we went commercial, and then we've come back round, and then we've found partners that are prepared to fund. I'm looking at Catherine, because a partner that's prepared to fund an evaluation to then give us some evidence at the end of that. Yeah.
Yeah, I think the NHS, well, NHSX that was until last week, has got a really good funding stream. So they've got some really good funding streams for investment in, and it's not early tech, because you're all medical devices registered, and it's safe and proven technology. But there's some really good programs that come down. So there's a focus in the NHS on social care, on prevention, on artificial intelligence. So there's some big pots of money that come down. They still at the moment can be quite time limited, but with the move to ICSs, the decision around funding for digital and other technologies will come at an ICS level. And then you've got much more autonomy in terms of deciding on the return on investment, but getting that early. So the program that we've been doing is 12 months, and we've seen some demonstrable reduction in A&E admissions, ambulance conveyances, admissions to care homes. Admissions to care homes at £1,000 a week is probably, and that, I mean, that was probably pre-COVID. It's our patch is Surrey. They're quite nice care homes in the main, and that is an enormous cost for the local authority. The in-state hospital and conveyances, ambulance conveyances, a massive cost for the NHS. So bringing those two, the ICS coming together and looking at that end-to-end pathway, the business case writes itself.
Another question at the back. Can we just maybe get a mic back to the gentleman right at the back?
Thank you.
Sorry, just first gentleman back there, and then
Thanks, yeah, just following on from that. I know you're from the ICS, Mid-Surrey ICS, but it's not very clear where the budget responsibilities are going to lie with the ICSs, because obviously there's the former CCG, which had health responsibility, the council's responsible for social care. So where is that happening in different ways around the country, or how's it? Yeah, if you can just say a bit about how that's going to work.
Yeah, so I mean, it isn't yet completely set out. It isn't completely set out. So the statutory body will be the ICS. They will have the same responsibilities as the CCG did. The funding mechanism will be through grant mechanism from central government based on population health needs analysis. The mechanisms, the exact mechanisms for how that's going to happen is not yet been determined. So the guidance is coming out as we speak. What is seeming reasonably clear is that responsibility for digital and data strategy and investment will be at an ICS level. So that gives us the ability to bring those scale digital solutions across and invest in those on a much bigger footprint. But there's loads of complexities in there, and it's being worked through as we speak. But it's definitely, to my mind, a massive step in the right direction.
Hi. I have one, let's say, more practical question regarding the technologies which are used nowadays for purposes of monitoring. So are there any kind of solutions that is like governmental supposed to be used, or is there something you want to buy and then integrate to other solutions, or how these things are actually working nowadays? Thank you.
I don't think there's really much coordination from what I've seen. So it seems like there are disparate groups of the NHS care homes. Everybody's operating separately, and nothing's really pooling it together. So people are making their own decisions, and that's proving challenging because then the technology doesn't talk to each other. So inevitably, you can't leverage the full spectrum of data that you're collecting. So I think perhaps on a policy level, maybe there needs to be a bit more coordination. But then again, the challenge with that is that then you've got new technology coming in all the time. And if you're trying to standardize, how can you ensure that you're bringing in the best and the latest technology? It just seems very difficult, and I'm not sure what the solution is for that. But Catherine might have an idea.
Well, I've got just another follow-on question in relation to, I was on a panel last week and I was asked about the the larger tech companies getting out of health tech and kind of realizing that it was a bit of a hard nut to crack. And I think it all links back to things like, 10, 15 years ago, where the NHS was trying to create a wonderful sort of IT infrastructure and it all fell apart. It's really complex. And I don't really see a point in the future where it's not. And I think that's really going to be a challenge for a long time. So all these disparate things, as you know, are intractable from a company like Google, who want to have, ubiquity and simplicity and platform-led technologies. And I just think they've realized that it's not going to happen very, very soon. And those things flow all the way through the NHS systems. Traditional care is impossibly difficult and complex and interconnected and full of paper. The future's full of all sorts of other computer systems that are disparately linked at the moment. That's how it looks.
Yeah, I think one of the things that's interesting is that the consumer market's starting to have an effect. So the bring your own device is like becoming a reality, and the NHS doesn't cope well with bring your own device. And government structures don't cope with it very well. So we just said, we'll allow people to use their own tablets. And the NHS went, oh, no, you must provide them with a really rubbish tablet that must be locked down, must have device management. And no, you can't give them a password that's locked in. They're people with dementia. No, you definitely can't give them the credentials locked into the tablet because that's not safe. Hello. That's the kind of problem you're going to face. And so I think, like we're hardware agnostic, so we'll be having a conversation after this, because the whole point is we're saying we just can integrate lots and lots of things in together. But I think what we need to do is get better get onto the data standards. So we've done some work, again, it's NHS, but and local authority around data standards, and it's all medical driven. It's interventions, surgical procedures, diagnoses. As a physio, I'm like, I don't really care. How are they getting out of a chair? There isn't a code for that, or there is, but no one uses it. So I think we've got to, for me, one of our things is about getting the data standards. So we're working in Surrey, we're applying for funding to try and get the data standards better for some of the softer stuff. They call it like the soft signs. And I think that will then allow a technology to sit on top of that. And that's where we need to get to, is that sort of like the creating the data standards that mean you can tip your stuff into a data lake. In Surrey, I don't think I'm speaking out of turn if I tell you that the data we collected, the only way they could cope with it was in a CSV file that would go and sit in a file in a system somewhere, because they didn't actually know what to do with what I'd given them. And that breaks your heart into a million pieces. So I think we have to I think there's a bit of that data standards. And I know there's been some stuff just recently about AI and getting data structure so that you can actually start putting this stuff together. And I just think that's where the ICS has to really come together, like health and social care, and AHPs, like allied health professionals, need to get in and start muscling in the doctors.
Right, I'm gonna come and ask you in a minute about NHS Direct, NHSX, and what happened. You'll know the inside track. I'm sure we'd like to know. But Zeke, first of all, just going back a few steps to kind of commercialization and creating a business model, I suppose, around a technology that you're trying to get into an established healthcare system that's potentially got a few rough edges and incompatibilities. What's your strategy for that as an entrepreneur and someone who's trying to jump into that world with the technology?
Yeah, it's very challenging. I mean, I think I'm quite fortunate to have that academic grounding for what I'm doing. So having had the opportunity to develop the technology with a care provider, collecting some evidence, and then being able to justify additional work to carry it forward. I know there are people that aren't in that situation that are also working in this area, trying to create health tech businesses. They have the vision, they have the drive, but they don't really have that evidence to start with. And inevitably, it's difficult to get traction if you can't say, look, these are the benefits. So I think it's really a case of supporting those very early stage businesses to be able to demonstrate the benefits of their technology potentially. So in terms of my sort of own journey, I'm really trying to carry forward the work that I've done through some additional feasibility studies. So working with people with dementia very closely, collecting additional data to support the use of the product, the wearable. And again, also quantifying the health economics. I think that's very important with these sorts of technologies. If you want to get into the NHS, you have to be able to say, look, these are going to be the cost savings if you introduce this technology. And it all costs money. So really, I think we need a lot more willingness from the investor community to take risks with these sorts of technologies. They're going to have a tremendous impact. Certainly with dementia, we're seeing, you know, a real surge in the number of people that are developing dementia. So, you know, it's an opportunity. It's something that's growing, and there's obviously that social impact as well to really make a difference.
Just before we move on, the investors in the room, are they still here? I forgot where the hands were. Who are the investors? They haven't all left. They've all left to go early finish for the investors. Never mind. I was going to ask them if they're investing in sort of an NHS destined health tech, and I'd be really interested to know about that.
Can I just, sorry, just to add to that, just to say that I'm sitting here thinking your smart socks should be in John Lewis, because we're obsessed about getting into the NHS, and actually we're all our own health managers now. We do so much for our health before we've even touched the health system. So actually, we've got to get it so that these things are just available for anyone to use, and that they just so happen to be really brilliant for people with dementia. Because I guess, as a stand just gone over there, but that early detection of problems, you know, Parkinson's disease, just as an example, most people have had Parkinson's disease for 5 years before they get diagnosed. So they've only got 10% of the bit of the brain left, the substantia nigra. They've only got like 10% left when they get diagnosed. They're that depleted. That is scary stuff. And that is the point that we need to get this in. So I think part of it is daring to say, we've had this conversation, haven't we? A commercial product, what is the other place that this can be of benefit? We're doing a trial in Portugal, and with people with dementia, they've just we did this walkthrough yesterday, and the families have all said, brilliant for mum, but I'd like a kit for home for the teenagers, please, because we leave teenagers on their own at the weekend, and we don't know what they're doing, and we would like it at home, please. Can we buy another kit? Of course you can. There's not going to be a no from a commercial company to say no to that, but that's what we've got to do. We've got to follow that to give it the validity. So smart socks in John Lewis, right?
Fantastic. So I don't know if everyone's aware of the sort of merger of NHS Digital, NHSX, and NHS England. Have I got that right? So, you know, NHSX being this big fanfare organisation created, what, 2 or 3 years ago?
Matt Hancock.
Okay, let's not talk about that. And I think it's interesting how this kind of, you know, constant process of sort of integration and you know, change always happens in these big organisations. But Catherine, what's going on with that, and where does it lead us, especially in terms of what we're talking about now? But you know, start with the general.
So I'm not an NHS professional by background. I've been in the NHS for 2 years, so I joined precisely at the same time as COVID. Hopefully haven't, yes, exactly. Hopefully have had a slightly better effect on the NHS than COVID. but my background is banking, financial services. And I just wanted to come back to this thing about data standards and integration. in banking and finance, we've got global standards for processing of payments, for example. And that has been driven by commercial reasons of needing to be able to trade globally. And the NHS does have standards. We have a data dictionary, PRSB data dictionary. We have FHIR integration standards. There are APIs, all of the things that you would expect an organisation to have, or a regulator. NHS England is our regulator and standards setter. They are all there. I think what's missing is that obligation to comply with those, and that's because of the state of legacy tech. So and the vendors have got a massive part to play in this. And anyway, so if I was at an NHS conference, there would be people from the vendors who've heard me say this constantly over the last 2 years. Companies that hold on to their data within, and have proprietary reporting solutions and will not allow their data to flow out of their systems, and don't comply with those standards, should just simply not be allowed to be in receipt of public money. So there we go. That's my bit. So it's not that the NHS doesn't have those standards; it does. So that's the first bit. So when I joined in my first couple of months, I was just utterly bewildered. So I had these briefs from NHS Digital, and they're setting the strategy, and then they've got NHSX, a bit more funky, bit more cool, and they were setting the strategy, and they do some really cool stuff with startups. So there's a whole process called DTAG. And the NHS brand might have gone, but the structures will still be there. So there's a whole set of projects and people really curious and interested in startups, and so DTAC, I'll connect you in with some people. And and then the NHS is regional. So I've got a regional digital team. I've got one for secondary care, and I've got one for primary care. And my head just exploded a few months in. I was like, who is setting the tone? What do I do locally? What happens regionally? What gets done nationally? So national products like the NHS Spine, which is the record of all of us. And then what gets done by NHSX? And it was just massively confusing. And then the Laura Wade Geary team came along and said, we want to talk to ICS leaders. And I probably wasn't as kind of circumspect as I maybe would be now. I was just like, my head is exploding. Who is setting the strategy? Who's setting the stone? Who's setting the rules and the tone of all of this? And there we go. So they clearly listened. And so thank you, me, for that. So what is going to happen is that the under Tim Ferriss, digital will come under transformation as part of an integrated transformation unit, and I think that is a really good thing. I think that is a really, really good thing. It will streamline the programs. It will streamline the contact points. It should give NHS England real good leverage with suppliers and the ecosystem, and hopefully I'll make it simple for me to understand who's setting the strategy. That'll be NHSX. NHS Digital will be like the IT department, so they'll do the big kind of core systems we all have to use and look after the kind of plumbing and infrastructure, cybersecurity, stuff like that. And then there'll be a national data, well, there is a national data strategy, and there'll be a lead for that. But all of that will come under the major transformation programs. So I think it's a really good thing.
Okay. Good, brilliant. And in terms of like impacts on healthy aging and technology investment, as it were, innovation programs, is it super clear what's going to happen, or is it just all up in the air in terms of where the money's going to go and where it's coming from?
So the detailed integration plans haven't been published, but the direction of travel around simplicity, integration, speaking with one voice, all of that has been set out. And as I say, I haven't been in the NHS for very long, so I still have Zebedee enthusiasm in the organisation's ability to deliver this in a coherent way. And the reason why I'm still so enthusiastic is the vaccinations programme. So if you look at that and look at the tech, and if anyone, well, hopefully we've all had at least 2. I've had 3 vaccinations. My process was end-to-end digital. So from being called up to being sent maps to being able to walk into a vaccination centre, they know who I am, check my medical records, look at any counterindications, record that get back to my GP surgery, and all of that arrive on the app. And we've done that in 12 months, 12, 18 months. All of that is end-to-end digital. There's not a bit of paper in sight in Brighton. And that data goes into national data sets that allows for really targeted population health management and really focus ways of reaching out to hard to reach populations. So if we can do that and deliver 90 million vaccinations on top of everything else, then there's a really good platform to do other really cool stuff. I
Fantastic.
should work for recruitment for the NHS, shouldn't I?
Not the NHSX though, not anymore. So I'm going to jump onto in-home stuff because you're very much in that space. Are you seeing a kind of trend towards adoption in that area, kind of getting people out of hospitals, looking after them more? It's something we talk about a lot in terms of an area of focus commercially. We're really interested in that. Is the NHS really open to that, and is it coming out and happening?
Yeah, we've got discharge pathways. So discharge to assess has been around a while, which is you used to be in hospital, you'd get assessed, get set up, then go home. Now we'll take you home and do it all at the same time. So it streamlines that process, and technology is seen as part of that. It's still quite old school at the moment, but yeah, we're about to start a trial in Salford, providing our equipment at the point of discharge. And the question I'm asking myself is, can we shorten the rehab phase? I know it's coming out of my mouth, I'm saying that, but can you shorten the rehab phase, but then do another brief intervention if things don't stay as they ought to when people go home? So go home, they do their good routine, they eat and drink, and then they start to tail off. Actually, a brief intervention at that point. So I think there's that. I think there is a longitudinal approach to it now. So it's much less short vision. People are starting to think of the longer term. And from the ground up, there's a bit more integration with care. So we're starting to realise that the care needs to be right. So I think that is definitely starting to shift. And I think people more and more likely to have in-home technologies sitting there. And can we make use of those?
And is that kind of consistent with more complex pathways where people have comorbidities and they're sort of looking for multiple things at the same time, or all those things disparate sort of offerings?
I'm probably the wrong person to ask because I'm a symptom-based approach to what I do. So I deal with the symptoms. The diagnosis and the disease-specific piece is actually out in the home. They're still siloed at the moment, so it is still a challenge. But I think more and more with the integration with care, people are looking after the person, focusing on them being okay, and then taking the other stuff offline and taking them in to do those specific assessments. So I think treatment management plans now are much more tailored to the person and never more should be so, I think. And I think we should take a nod to some of the cancer specialties that have done a really good job of that.
Yeah, fantastic. So that's positive. So things are changing in the right direction, but maybe not quite there yet, as we might expect.
I think so. And I think there's still, for me, it's still very medical driven. It's still quite medical model. There's a sense that you have to have blood pressure, you have to have daily temperature, you have to have this stuff. And it's like, well, actually, older people, sometimes their temperature runs low and it's actually the last thing to go up. The first thing you notice is they're wandering a bit more confused. And I think we just got to embrace the fact that there's a millennials type young person approach to health. So they're embracing remote access to GPs, online GP consultations, happy with an app, they'll manage, but there's still a group of people that need more. And we're really in danger of having an inequitable service whereby if you're young and savvy and you've got a good capacity to deal with all the information you're being given, you'll do all right. And then people, if you can't read or write, you are in trouble. And we have to start thinking of those things as well. And I think that's something. So wrapping services again to make those things accessible are going to be quite key.
Yeah, fantastic. I'm going to open the floor again and just see if there are any questions in relation to those topics. So we talked about the NHS and the translation into this new form. We've got lots of potential opportunities there to create technologies and to get funded through the NHS and to deploy them. Are there any questions in relation to all those themes? Just a couple more, and I think we're going to wrap up then probably by past. So any questions from the floor? Don't be shy. Yes, another one here.
Do we expect this? Catherine, do you think the consolidation of these units within the NHS will make it easier and faster for innovation to get to the right place?
Yes.
That's ultimately the purpose.
Absolutely.
Yeah.
Absolutely.
Okay.
Anything that means that and this was a bit of a surprise for me coming into this sector, that everybody is looking at the patient. So everybody will say, I'm so patient-centric or service user-centric, and I've got the patient right at the very heart of it. And I use this example that when I'm looking at this patient, they've got a barcode, and when I'm looking at this one, they called FANK. So we're all looking at the same thing, but we're looking at it in different ways. And so joining up the view of what somebody needs in a really customer-centric way. So what do I need from all of these different health and social care providers? Bringing in the voluntary sector is massively important as well. So creating these we've got a program called Thriving Communities, and it's looking at the whole ecosystem of what is available to an individual, from their local neighborhood app, to a voluntary centre, to a charitable foundation in their area. So how can we actually create the ecosystems of support that enable people to thrive? And technology's got a massive place in that, and that moves us hugely away from that medicalised model. And that's only possible when you've got joint leadership. So I'm part Surrey County Council funded, part health. We've got within our executive, we've got, I think it's 5 out of the 10 roles are jointly appointed roles. So you've got that medical and that health and social care, that social care view together. And it's only when you bring right brain, left brain together that the magic starts to, I think the magic starts to happen. And of course, talking about bringing funding together potentially. We're not bringing funding together, but we've got joint commissioning posts. So one of the things that drives me mental in places is where hospital trusts are desperately trying to discharge people back into their own homes because it's the right thing to do, and they need the beds. And then you've got local authorities, and they're both bidding for the same care home places. So you've got 2 teams of people phoning up and going, I'll give you 800 quid. And then someone will go, no, I'll give you 950. So you've got this, you can have bidding wars that are happening for really scarce care home places, which bringing that commissioning function together. So having that joint commissioning, joint pathways, really thinking about bringing community assets to play, all of that will give the right environment for innovation.
Brilliant, thank you.
When it comes to ethnic minorities, what sort of challenges and approaches and solution, do you have an example how you address them?
Yeah, so I think it's really interesting. So we're doing some work in Leicester, and we've been working on how we translate the app, and we're talking about cultural translation. So I worked in East London, so I've been drunk in Upper Street a lot. Yeah, I worked in East London, and we had a really big Bangladeshi population, and their approach to older people very different to what my growing up was. And I think so. There's a real challenge. I was sat with a guy from the HSN, and we were just sitting there, and it's just we've got to have the staff from those cultures embedded in our teams to represent those cultures in what we're doing. And I think what we found with our technology, so I found Surrey really weird because I talked to lots of posh white people in very large houses and blah, blah, blah. I'm thinking, I can't relate to this. I mean, I'm from Oldham, and in Oldham, we have quite a different mix of populations. But I think what we've got to do is work out what's culturally right. So I worked in Trafford in Manchester. We had an area of Trafford where there were no care homes because that was where our South Asian population were. And they were still living in multi-generational homes. They're now at the point where they've had to build the first care home because now things are changing. And I think what we've got to do is understand not just translation, language. It's not just about translating my app into Gujarati. That's not what it's about. It's about, does it mean something to you? So I go and work in people's homes, and I'm saying, no, you need to stop preparing the meal for your mum. Your mum needs to get up and be preparing. But that's rude. That's rude. I need to prepare my... No. You're making your mum ill because she's not getting up and doing it herself. This needs to change. And that's quite a directional shift. And I've had quite a lot of those conversations. So I think it's really interesting because I think there's a sense of making things in different languages, but not actually understanding the very different cultural shift. And we did some work with a Pakistani group in Manchester, and we did frailty assessment, which picks up, we did use the Groningen Frailty Indicator, which is a self-report measure. One of the questions is, are you still affected by a bereavement 2 years later? 70% of the women in that room were affected because they hadn't been able to go home. And the bereavement was back in Pakistan, and they'd not made it home, and they never got over that. And so off the back of that, the group brought in bereavement team and actually did sessions around moving on and dealing with that. I'd never seen that before in a group. And I just think it's really really interesting. And I think it's something that we need to, I think, like I say, Richard Stubbs up in Yorkshire and Humber is doing some really amazing work on that. And what he's saying is we have to have the cultural representation in our team. So we've just been talking today about how we recruit people from different cultural backgrounds into our customer services team to work, because they work with us on our pathways to make sure it makes sense. Because it's not, you can't just do, we're a global population, we need to get on with it.
Fantastic. Thank you for the questions and the answers. I'm going to, rather than do a sort of rambling summary of the session for various reasons, I'm going to just go around and give you all 30 seconds just to give us a take home. What do you want us to take away from this session? First of all, no pressure, Catherine. Tick, tick.
Health and care integration is happening. Bringing people together with multidisciplinary points of view from the very top of the ICS all the way through to service delivery is the absolute, to my mind, that's the silver bullet to help design services that are culturally and sociologically appropriate to people.
I think my take home would be that better aging doesn't mean defying aging. Better aging is about being able to do what you want to be able to do for as long as possible within what you're able to do. And I think technologies that enable people to carry on enjoying the things they enjoy are going to very, very important, and that we need to really focus on that. And I think that wearables have got a real future in this space. And I think that for me, it's really important that we consider the healthy aging, not just the diseased aging, because that's what we all aspire to.
I think probably more of a takeaway from the Giant Health event generally, rather than this particular session, but I've been surprised to see how much of an emphasis there is on machine learning and AI. And I think certainly that preventative or preemptive approach is obviously something that has advantages. We have to be careful how we do adopt AI, and we have to ensure that we ask the right questions of the data. And obviously there are a range of ethical considerations as well. But I think there are some really incredible opportunities there. And I certainly am very excited to see what happens in that space. And that's something that we're also working on with our smart socks.
Fantastic. Kashmir smart sock.
Kashmir smart socks.
Yeah. And I'll just wrap up with a view on that as well. I think so. I think what excites me, I suppose, and since finishing university many years ago, I've been completely in an innovation sort of mindset that whole time, which is very chaotic and not very sort of direct and straightforward. It kind of really relates to the NHS and to health in general and the stuff I raised earlier. And I think that's really such a great opportunity. If big companies can't work it out, I think it really does open up the opportunities for smaller organizations and people working in niche areas to kind of really do great stuff in those spaces. And I think that's really what I want, us to take away as a positive from the chaos and from the lack of simplicity from Google's point of view, and revel in it and make it happen. So thanks everyone for coming to this session. Say again.
So thanks for staying.
Oh, thanks for staying. They want more. They would be here till 5:30 if we'd let them. But you can only have this much. We'll be doing another show soon. Ticketed, isn't it? I think it's quite expensive. Yeah. Never mind. So great to see you all here. Thanks for coming. And we'll all be here next year, I assume, in the same venue. Less COVID, more Giant Health.